So, good morning, everyone. I'm Dr. Manoj Patruni. I'm working as a cardiovascular health officer for Odisha State and looking after the project called IHCI for WHO India. So today, I just take this opportunity and thanks to the organizers for giving the support. And this particular session, I just wanted to brief up what is actually the intervention for these cardiovascular diseases from this IHCI, what is supposed to be. So as I talk, we need to know for any of the intervention to be there, it should be a public health burden. So if there is some burden, definitely we want some thoughts, and with these thoughts, we'll need to some innovations or interventions. So basically, for that purpose, we need to know the burden of the disease. So as all these 3 days were going on, and many of you are residents and other program officers are there, managers are there here, and you are aware right now why we are focusing on non-communicable diseases. Out of all these non-communicable diseases, the major silent killer is hypertension. So this is the only main disease which is leading to all these complications, and invariably the major deaths are due to the heart attack and stroke. So these two are the main diseases which are leading to the major mortality, and government has given an opportunity to WHO and ICMR, and this is a multi-partner initiative which has started called India Hypertension Control Initiative, where we are supporting the NPCDCS program. This NPCDCS program is all about what we are talking all these days and all the components what it deals. In this NPCDCS, we have population-based screening for all these diseases of non-communicable diseases, that is these hypertension, diabetes, cancers. But supporting this, IHCA is giving the management of this hypertension in primary health centers. So management of this disease is also very important to reduce the mortality, and we have a target mortality to be achieved by the government of India. That is, we need to decrease 25% of these mortalities which are occurring due to cardiovascular diseases by 2025. To attain this, we need to identify what is the primary hypertension, how many are from primary hypertension, or how many of them are suffering from secondary hypertension. For this, we need management. For this management, we got some components. All these components put together, they are elements which are taken from WHO HEARTS package or HEARTS element, what we'll see next. So for this, I'm directly going away with few slides, which all the other speakers were speaking for all the last 2 days or 3 days. So this is the burden. You see in 1990, there is respiratory infections, that is TB, that is communicable diseases are leading. And then once you come to 2017, NCDs, so non-communicable diseases, whatever age group it is, if you see from 15 to 49, the sufferers are from NCDs only. And then if you see 50 to 69, from first itself in 1990 also the same NCDs were there, and 2017 also the same NCDs are there. So this much is what the problem of NCDs today. And you see this particular slide, putting together all the other diseases gives rise to less than the high blood pressure prevalence. That means the mortality is more due to high blood pressure when compared to all other non-communicable diseases or communicable diseases. So that is the main problem. That is the only issue why we are particularly discussing this hypertension today. So you see the prevalence overall, it is 24.9%, which is according to the survey in 2017 and 18. And then put together in India, India is the only country with high number of hypertension patients. So when we are going to the burden, this is already discussed, and it is 2019 statistics. According to 2019 statistics, 17.9 people are suffering with CVDs. Million people are suffering with CVDs, and it is estimated 32% are resulting deaths from this particular thing. And immature deaths are the main what is concern for us as a public health personnel or any clinician is concerned. So we don't want anyone to die before the age of maturity. The immaturity is nothing but less than 70 years of age. So that is the main concern of any public health concern. So as such, NCD, that is the overall CVDs. So this is the burden of hypertension which is there now. So 1.28 billion people of 30 to 79 years age are suffering with hypertension, and all the students are aware. Residents are also aware, and many of the program officers will be also be aware of hypertension. It is nothing but the rule of halves. The rule of half is applicable, and it is the same which is being projected in the picture also outside, that means in the field. So out of this, you see 46% adults are unaware that they are having hypertension, and approximately 1 in 5, that is 21%, is having have hypertension in control. That means it is poor control. So India Hypertension Control Initiative is developed for managing and controlling this hypertension in primary health facilities. So why we are more bothered about this hypertension? Because it doesn't have any symptoms where a person can be walking, he may not know he has hypertension, he has never checked for his blood glucose. He or she has never checked her BP. So they may faint immediately, or they may have a headache or something, and they may land up to the, they get palpitations, they land up to the facility. And yesterday, as Dr. Anand sir was also projecting about the study from Faridabad, the people before reaching the facility itself, there is half deaths which is happening because of this severe cardiovascular diseases, mainly because of hypertension. So this was a previous speaker on research. The slide was projected. You see the control rate is very much less. And the awareness, this is the STEP survey which is being conducted, and 17-18. Only the rule of halves is applicable here. The people who are aware is not 100%, and from those awareness, even not 50% are under treatment, and that 50% in treatment, there is no control in those 50% as well. So how important is this hypertension? If it is like you check for your blood pressure at least once in a year, you can decrease the mortality if you go for the checking of your blood pressure earlier age. That means if you go at the age of 40 to 49 and check your blood pressure, if you are diagnosed with hypertension, or anyone is diagnosed, definitely the risk of getting the vascular mortality will be reduced by 51%. So the only thing is, earlier the intervention, definitely you can prevent the deaths. So this is all these two slides are taken from the many prospective studies which has happened till date. And there are 1 million adults in these 61 studies. So this is the studies which projects that observations that lower the blood pressure by 115 mm of mercury, then lower the cardiovascular disease risk. So on a outset, like totally what I have spoken for this 10 minutes of time, this is what is all hypertension about now. So only 1 in 4 people have high blood pressure in India, and approximately that is 20 crore people. And then 1 in 2 have been diagnosed with high blood pressure. And out of this, 1 in 10 has only got in control. So as a result, we are having this heart attack, strokes, and kidney failures. So we won't want this to happen. So this is globally. For any control, as public health is concerned, we need some intervention immediately for any burden. So these are the countries which have taken some initiative, and once you see the control is achieved 68% in Canada, followed by USA and England, Thailand. So 68%, why did Canada get it in 2013? Once we just put in our thoughts, or we just think about that, it is because Canada has adapted a system to diagnose and manage this hypertension, which many of the countries have followed. So this is the lessons which is learned from the Canada program. So in 1999 to 2010, so if this is the advocacy and healthy food policies, all these put together, they were able to achieve this good control, which developing countries are still today. India also didn't attain that. So based upon all these things and based upon all these learnings, we are also on track, and India Hypertension Control Initiative is doing wonderful job in 21 states right now in all over India. So I wanted to discuss a bit about this program. So, because this stage is set for interventions, and this is public health approaches towards non-communicable diseases. So, this conference is all about. So, this would be a very good operational research what is happening in the field. So, this is the same thing what we are talking all about, and this is from Thailand. I will skip all this. So, this altogether, India Hypertension Control Initiative wanted to accelerate the progress towards 25% decrease in raised blood pressure. That is, we wanted to achieve the target of decreasing the mortality by 25% by these non-communicable diseases, cardiovascular diseases by 2025. For this purpose, we take all these 9 voluntary global NCD targets are there, where IHCA focus on premature mortality from NCDs, that is 25% reduction, then raise blood pressure reduction by 25%, then drug therapy and counseling of 50% coverage, and salt or sodium intake by 30% reduction. These 4 things are the components of what ISCA is all concerned about. So what is the national action plan towards this cardiovascular diseases? So it is 25% relative reduction in the mortality from CVDs and 30% relative reduction in mean population intake of salt or sodium, and 25% relative reduction in the prevalence of high blood pressures or the raised blood pressures. All this put together, we wanted to achieve in the existing healthcare system. There is no additional HR, or there is no additional budget or whatever is not being provided from anywhere. It is all which is there in the existing system. We need to use that resources only to achieve this target. So what is all about this Global Hearts Initiative? This is what they adapted from WHO. So, and this is WHO and partners in 2016 to reduce heart attacks and strokes. So we have 3 packages mainly concerned with hypertension. We have the package of hearts technical package to strengthen the cardiovascular diseases in primary healthcare setup. So as this element says, IHCI program is strictly based upon these only elements, 6 elements. That is, starting with adapting healthy lifestyle, evidence-based treatment protocols, access to essential medicines and technology, then risk-based management, team care and task sharing, systems for monitoring. All these are discussed previously by many of the professors and other colleagues as well till date. But in specific, in a nutshell, put together, the program is of all these interventions included. That is, all these elements are included. So I just wanted to make it a 2-way process, not a single-way process, like only the speaker will be talking and you'll be just seeing. I want some resident to just respond on healthy lifestyle. What is a healthy lifestyle about? Any resident? Or I will pick up someone. Someone can voluntary on these elements. Yeah, I want the residents to answer basically. Okay. What do you mean by good diet? What is balanced diet? You don't give me viva answers. You need to give me technical answers. You don't say balanced diet. How will you calculate balanced diet?
Like,
like
we have to take enough of fruits, like diet which is balanced in carbohydrates, fats, proteins.
how much?
Um,
So you measure the carbohydrates, how much you take in diet, maybe 25% of carbohydrates. How will you calculate that?
like 5 servings of vegetables and fruits.
So everyone can do that. You
Even
have
we
knowledge
can do that.
and you are a community medicine resident, so you have knowledge, you are able to do that. What about others? We are targeting the all types of population, not only you or anyone else. So what else is healthy lifestyle?
Dealing with stress.
Pardon?
Stress, sir.
Healthy lifestyle is stress.
Like dealing with stress, sir.
Okay.
Stress is stress has become our part of life, but we have to deal with it.
So for that, what you wanted to do?
Maybe practicing yoga.
Adapt something. Then what is the primary cause of all these complications in healthy lifestyle? What you don't want it to do?
Being physically active.
physically being active. Next, we don't want tobacco, we don't want alcohol, we don't want everything put together into our minds running together. That is your stress. Again, you wanted to do something, you wanted to achieve something, you don't want to put my bundle of targets. So then you'll have a healthy lifestyle without these addictions. Okay, fine. Next, what is evidence-based treatment protocols? You can answer yourself. Yes, you give it to him, this young person there.
What I understand by evidence-based is like something which is studied and approved and researched properly and explored, rather than you are finding a new technique and implementing all of a sudden.
No. By evidence-based treatment protocols, what you wanted to achieve? Why you don't wanted to go for a normal treatment? Like, matlab ki you are a physician, general physician. So someone comes to you, you can directly right away whatever drug you want. You can start on statins. You can put him on
Yes,
calcium channel blockers or something like that.
according to me, if you don't have a data, there doesn't exist anything. So evidence-based is like data-based, research-based. So it's the data-driven, and if we have a proof, so
That is okay.
we are not doing
Evidence-based is
anything blind.
you justified for evidence-based, but only thing I'm asking for a protocol. Why you want a protocol?
Protocol so that it is systematic, so it is uniform all over the country, so that there is no confusion.
So
it's a systematic
to
based
be more precise in the treatment part and to be uniform and to be simplified, it can be administered by anyone, any category of healthcare providers. So that is why we wanted the protocols. Next one. Yeah, yourself. So what is all this access to essential medicines and technology? Why we wanted this?
For NCDs, we have medicines and technology, but that accessibility to people. That's what we were talking about, the people-centered care. So accessibility to essential medicine is important. So primary healthcare is taking part on that. And the technology, now
How we can achieve? How we can achieve this? I'm not asking meaning of that. How we can achieve it? How
through
you can
local
provide?
through
Yes.
health workers and ashas. So by through
No,
through
once
them
the
we
drug
can
is
promote the
available.
people.
No. You didn't. You got my point wrong. Once the drug is available, then only there is all these things coming apart, right? So you need to see that essential drugs are available first. For that, you need more. You wanted some technology to be adapted, like you wanted to indent the drug, for example. So how you will do that? You have to get some technology. Yes. How you'll maintain that supply chain?
From
So 5 minutes more for the discussion.
Yeah, I'll complete. There is nothing left. This is done, the program is done, that's all.
from tertiary care to primary care, the supply chain should be maintained and it should be monitored whether it is perfect, and if there is any delay in
Any
processing
gap?
or imbalance, that should be ensured.
Okay, good. Now next one, you can give him back. Risk-based debt management. You can answer what is risk-based management. Already we covered yesterday this topic.
Management of the factors.
How? What you are doing for that?
To
What is meant by risk-based approach basically?
counteract the disabilities and the complications.
You wanted to go for the targeted population. So the targeted population should be screened. That is what we are doing in this population based screening also. And we are taking this targeted population and then we are giving this protocol based treatments, or we are going to refer them for their further management to the primary center, from the primary center to the tertiary care center. If at all he or she is having secondary reasons or secondary causes for these diseases. Okay, next. Team care
Sir,
and task
can we
sharing.
continue this in the mobility break? Dr. Harshal, the next presenter is already here.
Yeah, okay, fine.
Okay.
I got some time or it's there? We're done.
Sir, 2 minutes maybe?
Yeah, okay, fine.
Okay, thank
So
you.
just go across the slides because we already covered all this right now as per the discussion. So this reduction of cardiovascular diseases, we have policy front and then we have the clinical front. And clinical front, we have this ISCA program all about. And this is the essential treatment components of this IHCA as what we were discussing. This is adapted from those elements of hearts only. That is the package. The information systems are nothing but we have an information system for every program which is useful for monitoring and evaluation. Any program is there, we need to monitor and we need to evaluate. If there is any issues, then only we will be knowing that based upon the performance of this particular program, we can go for another further interventions so that we will achieve the desired uh, goal. So that much is necessary. And IHCA has a simple app. Everything is put in that app. So you got every data which is available for hypertension and diabetes through this. So that is the system which is adapted. So this is how the protocol would be. Anyone can administer. It will start with one drug, combination of 3 drugs at the end. Maybe it can be for a 1 month period to 5 months or 6 months in particularly many states. For Odisha state, I've done with 3 drugs with 5 months period, starting with amlodipine 5 mg with hydrochlorothiazide 12.5 mg. So all this is the same what we are talking about. By the end, I just wanted to tell one thing. This is the progress of IHCA. We have 38 cardiovascular health officers in all the country. It is in phase manner. So this is most important, and I wanted to end with this. You guide your parents and thereby your parents to your friends or somebody, whoever is there. But above 30 years of age, I request everyone to check your blood pressure at least once in a year. This says once in a year, but practically we say every 6 months once. Thank you for this opportunity.
Thank you, Dr. Manoj. We can have the question in the mobility break.
It is evidence based because we take JNC 8 classification as consideration to. Okay.
Next session is by Dr. Harshal Salve. Sir is additional professor, community medicine, New Delhi. Sir, the stage is set for you.
Okay, so this is what? Second last day of the course? Yeah, exhausted? Energy still left now? You have one more day to go, right? Yeah, excellent, excellent. That's what I want to hear from you. Right, right. So, this is second last day, and hopefully all theoretical aspects has been covered, right? And we have been last 2 years, and I think after 2 years we will be having this physical workshop in the course. Why? COVID-19, right? COVID-19. So COVID-19 was what? It was an emergency situation, health emergency situation, right? And emergency can be health driven, it can be calamity driven, right? So in this situation, in such situation, how we should focus on the NCD services? That was the question which was discussing since before COVID also. If there is a natural calamity, be it tsunami, be it earthquake, cyclone, right? How we should ensure the continuity of the NCD services. Why continuity is important in NCD services? Because it's a chronic disease. Compliance is critical, control is critical. That's why we should not, we should ensure the continuity. But what happened in our place? We have stopped all, we have closed all hospitals, we have ensured only emergency services, what not and what it is, right? So it is important to study how we should ensure the NCD services, continue NCD services, what should be a plan. This is again a learning curve for all of us, not only in our country, outside country also. And this was an opportunity. COVID was an opportunity, I will say, apart from the challenges, how we should prepare ourselves for continuity of the NCD services, or for that matter, any service, health services, because we are discussing NCD here, so we'll discuss more upon it, right? So this is the framework document which is available, prepared by WHO for Southeast Asia region for integration of NCD care in emergency services. So if we really want to continue NCD services, we have to include it in our emergency response, right? All of you are aware that, and as I told you that day, we have this national program for climate change and human health. Most of you must be looking after it. So preparing for emergency situation is the key component under this program, right? And now you being by virtue of handling both the programs, it's your, and it's easy also, and it's your priority also to keep NCD in the part of it, emergency. Why? Because NCD is major driver for mortality, morbidity, continuity of services is required. So that has to be kept. Okay. So the WHO has given this document, the framework, but there is no local sort of framework available for the country, right? So because we should thrive for the specific local, I will say the district specific framework, but at country level did not have any local framework. So what we did was, with the support of WHO India office, Dr. Pradeep, Dr. Fikru, and with the Ministry of Health support under the guidance of Professor Anand, Professor Baridalin, we embarked on this exercise of estimating or assessing the NCD services in the country during COVID-19 pandemic. Because as I said, this was an opportunity. So we assess NCD services at various level in the select states. I will briefly touch upon the background. We all know, though there was a guideline from the ministry that you should continue all the services in the midst of the pandemic when the lockdown was lifted, but still there was an issue. So with this background, and we formulated this objective to assess and document best practices. Again, we were in the background, we were aware that lockdown was there. It was a sort of forced lockdown from top to bottom, right? So our objective was not to identify the gaps and the fault finding. So our objective was to identify the best practices, how states, districts, be it a health facility, responded to this pandemic in order to continue NCD services. That was our objective. And the larger objective was to prepare a guidance framework for future time. Definitely there will be future health emergencies, as I said, other emergencies. So what should be the guidance framework? How health system should respond? How should government should respond with respect to the NCD services? That was a major objectives. So it was a cross-sectional study. We did it for April 2020, 2021. So it is a mixed design. It has a record review and interview with the stakeholders we carried out. So these were qualitative assessment, quantitative assessment, qualitative assessment, all based on sort of interview with the states, UTs, stakeholders, their manpower, money, how they are managed, what are the best practices. And quantitative assessment, we interacted with all the state program officers, got the information regarding the data, pre-pandemic data, post-pandemic data, just to see how NCD services, in what component of NCD services got affected. The slides are crowded, don't look at the slides. Just yes. So these were the sites where we conducted our assessment. You can see it was almost covering all zones of the India. I will not say all states, but all zones are covered, represented. So almost 20 districts, 23 districts are covered, and two sort of districts in each state are included. We chose this district based on the NPCDCS performance review, what we did in year 2019. The program officer must be aware of it. So one good performing districts and one sort of low performing districts were selected in the each state, and the field visits were made. And we tried to contact all state program officers in the country by the and we did a virtual interviews of the state program officers. And these were the 10 institutes. Again, it was a really team effort, and we have people from other aims also, other institutes. So it was a team effort where during the pandemic also last year, everybody went to the field, all faculty members, their senior faculty members also, they went to the field and carried out this exercise and helped us a lot. And these were the sort of, as I said, the stakeholders, which were interviewed, starting from the district level, district program officers, medical superintendent, and also the district magistrate or CMO was also interviewed, followed till the end of ASHAs, the community level. Important part was also there. We also interviewed the private practitioners at each site. So they were also part of the study. Why it is important to interview private practitioner? Right? I will say 75% are taking treatment from the private setup. And most of the time it is ignored, their perspective, their challenges. So we try to assess their perspective here also. So these were sort of our focus areas: identification of the services, socio-cultural advocacy, management of human resource, funds, finance management, governance, leadership. Again, neglected part, communication and governance. This is very crucial in the emergency situation. How we communicate, how we govern, how quickly we take a decision, that is critical. And most important, IT. So how we used IT during this, so we have assessed that. Now, briefly coming to the result. So these are the state level interviews. The blue part is the state program officers we covered doing the virtual interviews. Each interview lasted for almost 2 hours. This interview conducted centrally from our team at AIMS. And the green level is the district level assessment. As I mentioned before, the team went to the district, visited, and each district hospital, community health center, primary health center, and health and wellness center in the districts were visited. We interacted with the all field level staff during the district. Now, result, as I said, 27 districts. So these are the services available, treatment available. Most of the when we have visited, most of the services were available at that particular time in the district hospital. Other services under district hospital, the cancer services. All of you must be aware, the state program officer. We are sort of, I will say, we have a shorthand as far as the cancer services are concerned, even at the district hospital, right? The similar picture was observed here. Another important thing is the behavioral related counseling. That was not given a priority during pandemic, but this is the overall assessment, which is also has been reported during this exercise. And we all know the health promotion component is really weak in our program, though it is there in the theory, there is in the manual, but is we are not implementing at the ground level. NCD clinic, reporting of the patient, you can clearly see here, there is a drop, right? Because of the lockdown, because of the panic created amongst the population. So patients were not visiting the health facility. So there was a clear-cut drop visible in the healthcare seeking as far as the NCD clinic are concerned. Now I will present brief challenges and the solutions which were there. Solutions are the local solutions observed during our visit there. So we have documented that in various domains. So as far as the routine OPD services, the challenges were footfall of the patient were reduced, implementation, because this was there, COVID appropriate behavior. Nobody knows what it means, but what is the use of it, but still it was being implemented and it has its own challenges in providing services. Adherence to treatment difficult, OPD services closed during first wave. First wave mein to pura lockdown tha, right? During first wave. The lockdown was not there in the second wave, but during second wave, what was there? Panic was more there. So reversal was there. When there was no panic, we had a lockdown. When there was a panic, we didn't have a lockdown. So on both sides, the services got affected. So what were the local solutions they adopted? The telemedicine services, telephonic consultation, triaging of the services, most of the places, the emergency, like if somebody is aware of the how CSC function, CSC has the emergency and OPD. At the most of the places, OPD were closed. So if the patients were coming, they were treated in the emergency services as a for drug dispensary. Mobile medical vans for follow-up in the few states has been reported, and doorstep delivery of the drugs. Few states also reported doorstep delivery of drug using the ASHAs or voluntary groups. Increased duration of the prescription, we usually give 7 days or 15 days, but in the few states like Uttar Pradesh, what we have seen that 3 months medicine was prescribed from the OPD services. Specialized NCD care like IPD services, All elective surgeries were postponed, and the shortage of inpatient beds, because what happened was the all inpatient beds were transported into the COVID facilities. So patient referred and shifted to non-COVID declared hospital. There was a declaration, there was a demarcation of the COVID facility. All of you are aware, and non-COVID facility. So there was a geographical issue. The distance, patient had to travel more because there's a designated hospital was there. So that was there. But at some places, like in Kerala, they have arranged the referral facility. Suppose if patient comes to the COVID facility, they have arranged the referral facility to the non-COVID facility from for inpatient. Daycare procedures, this is the most affected part. The daycare procedures like dialysis. At some places there were chemotherapy. So dialysis was the most affected services in many districts. The compliance got affected, but at some places, because I have visited Uttar Pradesh at that time, so they kept this dialysis unit open, and they are specially communicated to the general public that sort of regarding the continuity of the dialysis center in Lucknow. They have the dedicated center there. At some places, ma'am is there. And we have interacted with ma'am, if she remember. I came to Lucknow, I interacted with ma'am. Yes. And I know we have the state program officers. If some name of the states come, don't take it personal, right? So that's a disclaimer I forgot. So as I said, we interacted in the ma'am in her cramped chamber. I really, she is handling everything during that COVID times. So machine dedicated facilities was there. Some private facilities are also designated for dialysis. Emergency services, unavailability of transport for non-COVID patient. Most of the there we don't find any solution. But emergency services are continued, continued in most of the places. Referral system in Maharashtra, it was functional, but almost a routine referral was used. The routine referral was also used by your MCH and other diseases. So it was not dedicated referral for NCD care. Coming to the laboratory services, you can see here the basic laboratory facilities were available in most of the places, but other advanced, I will say, though it is considered as essential, but they were not available at almost half of the places. Non-functional laboratory services, you can see here 19% laboratory services were absolutely non-functional, because major reason was the diversion of the human resource. And that, then coming to the challenges, all the states, again I'm saying, don't take it personally, Himachal and Punjab, that was our finding. The laboratory services were closed, and deputation of the lab technician, because again the lab component was sort of dominant in the COVID response. So most of the lab technicians were diverted. So routine care was affected. In Tamil Nadu, it was partially affected. In Maharashtra, they have outsourced the laboratory care that were functional, and hub of spoke model in the Telangana was a good example as a solution, because they were collecting the sample and distributed for the testing, right? So this is a good practice we have observed. And home screening of hypertension and diabetes of ASHA during COVID surveys has been reported in a few states, like again, I will say the Uttar Pradesh. We also, that I forgot, we also interviewed the patient as an exit interview during the health facility visit, so that to capture the patient perspective with respect to what were their experience during the COVID time. So you can see treatment discontinued almost is 14%. They have discontinued. Main reason were did not visit the facility, unable to reach the facility were closed. The communication was not there from the health facility side. Medicine were not available, and no doctor available for this NCD care. They are the few sort of reasons listed from the patients who discontinued the treatment. Again, you can see here the physical activity and routine consultation was the most affected domain as far as the health seeking is concerned, right? So other more or less which was there, and there was also a reporting bias when it comes to the substance use. But what we observed, the physical activity got restricted because of the various restrictions, and the doctor consultation got restricted again because of the closure or the restriction of the facilities. Awareness about the government initiatives, which was there, most of the people were not aware. Again, as I said before, for any pandemic response, communication is the key, and that's what we found to be lacking at the most of the places. Uh, and but few patients also reported, because we also treat this interview as a validation of what government has, means like government representative have told us कि हमने ये किया है. So we sort of validated कि सच में ये हुआ है नहीं हुआ है from the patients. So few examples or initiatives which were validated by the patients is the home delivery of the medicine by healthcare worker or ASHA, mostly in the rural setting. But again, there is a urban rural differential here. I will say here, the rural program was well functioning as compared to urban. The medicines were more, availability of medicine, I will tell that, I will explain that availability of medicine was more there in the rural facilities, in the rural setting rather than urban setting. There is a provision of the MMA card for free dialysis and the COVID treatment. The municipal corporation inform about the alternate facilities and NCD services, the screening of the blood pressure again through the ASHAs, because at most of the places ASHA did this ARI surveillance for the COVID, right, for the symptom checklist and other thing. So at some places this opportunity was used for NCD surveillance. Implementation of the key guidelines, again this is, as I said previous, for the patient perspective, this is what government guidelines was there. Teleconsultation online almost 9% was reported. Home delivery medicine again 12% only, and receipt of SMS 24%, and longer prescription, I will say that was a major initiative or intervention which was implemented 70% facilities. So as I said before, usually for the non-communicable diseases, we give 7 days or 10 days. But as a communication from the government of India, they have said that you give medicines for, let's say, for 1 month. This will do 2-3 things. That will reduce the visit of the patient, and also that will ensure the compliance of the patient by ensuring the availability. Population-based screening, these are again community level activities, how they are sort of affected. We all know this was the major sort of dent happened in the population-based screening. So all this activity got halted during the COVID pandemic. There was a fear, there was a restriction, there was a overburden, and obviously the isolation, quarantine, and all sort of things were there. But in Punjab, we have observed that the ASHA continued population-based screening and referred suspected cases from CHOs. Do you have anybody from Punjab? No. So, and also there was a telemedicine facility, so that a consultation was also ensured from the community with the specialist. And the camp head in the Maharashtra, the camp-based approach was there on the specific days, but no such other community-based activities was reported. Coming to the health promotion activities, the camps and health days were increasing awareness. But again, what we observed during COVID-19 was majority of focus was on the COVID-19, the isolation, hand washing, other thing. The NCD part, again, this is the irony. In the COVID also, we were at the maximum risk of mortality. Patients with the non-communicable diseases, but that was a lacking as far as the our health messages or communication was there. But at some places, the social media was used for disseminating information, and as I said, ASHA surveys, ARS surveillance was used for promotion at some places. That's what we are documented. Coming to the program management activities, similar thing, the shortage of HR, the task shifting was reported almost half of the places as far as the NCD clinics are concerned. And most of the places, these were the staff which were pulled from the for the COVID-19 management and with the most of the places. So as I said before, there was a deputation of the COVID-19 staff for the COVID-19. NCD clinic staff which were there at the CSC were pulled for the COVID duty, so they were not available. And there was a low remuneration was reported by the specialist. At some places, the solution like task shifting, role delegation. Again, I will give example of Lucknow, where the MS ensured that the NCD clinic should function continuously. That was the only place I found that we observed that the NCD clinic was running throughout the COVID pandemic for 2 years. They haven't sort of pulled not a single staff from the NCD clinic, and they have a good amount of the recommended staff there. So the mainstreaming of the Ayush people were used, the other program people like mental health, RPSP, they were used for NCD counseling. At some places, the recruitment was done, but not at most of the places. The private sector were involved in terms of the numbers of private practitioners through the associations were shared with the community so that the community can make calls and consult these people free of cost. Training again most affected in the first year, but second year the online sort of outbreak of the online training started, right? So that were leverage for the NCT training also. But there were issues reported by the state program officers that there was a issue of the knowledge gain and the concentration span and other things. But at some places, the hands-on training they have started slowly and steadily. Regarding motivation, health workforce, the staff, most of the places, staff complained that they have arranged their own transport. There is in the initial phase, there was a harassment cases were also reported and the workload increase. Obviously, the entire health facility, health workforce were on the sort of strain during this period. But some, to address these issues, some good practices, what we observed that the dedicated ID cards, the uniform of the community level workers were given in Kerala, so that had reduced the stigma. At some places, the highest sort of political leaders communicated to the population regarding the importance of the healthcare, so that were reported specifically from the Maharashtra, that were boosted the morale. Equipment supply again, it's very crowded figure, but the supply was, as far as the equipment and the, as I said, material and the drugs were adequately there. If you consider the basic supplies in most of the places, medicines, fortunately, because most of the places this medicine is outsourced to the corporation or some other third agency. So that was ensured well in advance. So most of the places there was no shortage of the medicine, and there was no issue of the availability. So against our expectation, there was no stock out as such. A major issue was reported. There was no disruption of the supply chain. The differential, again, as I said, the priority was given to the rural area as compared to urban area in terms of supply of medicine. But the repair of the dysfunctional equipment was affected during pandemic. At some places, some good practice in the form of private facilities being empaneled, some outsourced companies being empaneled for repair of the equipments, and shortage of medicine was also taken up, and with the local purchase has been done to ensure the supply of medicine. Again, this is the issue finance management. There was no, I will say, the major hiccups reported as far as the diversion of the fund. But expenditure itself got reduced due to there was no activity happening as far as the NCT was there. And local funds and utilized and untied funds were utilized at some places has been reported for purchase of the medicine, the repair of the equipment. But more or less, there was no issue with the finance. Again, a busy slide. As far as the IT data sharing, because no activities were happening, the NCD app, and nothing was happening at most of the places. So that issue was there, but because the reporting was again dominated for the COVID related thing. But good practices was reported from Tamil Nadu, has a separate system for tracking patient and compliance to treatment. The reminder registry, referral, and telephonic follow-up was also done for healthcare workers. And NCD registered were also used for cases and contact details for COVID. Review and monitoring, again, this is affected because the meetings were not happening. Most of the meetings were online. But there were few good practices like in Telangana, the monthly review by the district medical health officer, telephonic feedback. In Himachal Pradesh, the block level and state level, headquarter level meetings were conducted to review. During the COVID meeting itself, they have reviewed the NCD program also. This we're talking about the NCD program review. In the Kerala, what was reported, during COVID also, again, the importance of the NCD services has been given. In Andhra, a very good interactive voice recording system, which is IVRS, has been put up to check the quality of the services. And in Chandigarh, they have reported engagement of the private sector for monitoring of the A&M. Intersectoral coordination, again, this is again sort of, I will say that on the ground level, it doesn't happen pre-pandemic or post-pandemic or during pandemic. So the coordination activities were sort of not happening, but even if it was happening, but it is linked to the COVID-19 care. The private sector was not involved, interdepartmental collaboration was not happening. No guidelines of, again, this is an important thing. The guidelines of management of hypertension, diabetes were not shared with the private practitioners. As we have interviewed them, there was no communication from the government side or the local health authority to the private sector. But again, at few places, we have observed good practices. The community level rapid response team with the self-government and the each from the each ward, the local mechanism were used. In Tamil Nadu, NGOs were used. The participation, partnerships with the on the PPP mode was reported from Gujarat, Maharashtra. In Uttar Pradesh, the Hello Doctor initiatives was there, where the IMA was given a responsibility for online consultation, free online consultation. And again, NGOs, involvement of NGO was reported from the Odisha. Catch-up plan, most of the state did not consider during the catch-up plan. What did not they consider? The NCD services. And during their catch-up plan, the NCD were missing. The main activities considered during meeting of resumption of the services. Means like now, if you want to move into normalization of the services, what were the activities? The training was the first part. Most of the program officers reported that we have started training activities of the program officers, medical officers, ASHAs, population-based training. At the community level, Himachal and Gujarat reported resumption of the population-based training, and the follow-up and the improving percentage of patients and control were done in Maharashtra. Chandigarh also reported health promotion activities. And similarly, at various levels, the population-based training was resumed after the normalization of the situation. Coming to the use of technology, reducing patient-provider contact, the telemedicine was used, telephonic consultation, SMS-based laboratory services was result communicated, the treatment compliance using ADP application in Telangana, ISCI, we have just heard that it has you, particularly in the northern part in the Punjab, they played a good role in compliance making, and social media platform were used predominantly. The web-based capacity building, mostly this Zoom, WebEx were used for capacity building exercises, and mostly these social media groups were created for the program officers, medical officers for easy communication, and virtual platform were used for the meeting. So these were the good practices reported as far as the use of technology are concerned. Now, briefly, again, don't look at the slide; it's very crowded, very text. Crowded slide. So as I said, the second objective was to prepare a guidance framework for future as far as the continuity of the NCD services are concerned. So we have divided into four sections at every level, at the district level, health facility, and the community level, and what should be at the governance. As I said, governance is the key. So at the state and district level, advanced planning is most important, and unambiguous communication. What was we have seen during COVID-19 pandemic is on day-to-day basis, there was a revised communication. There was no continuity of the communication. There was no, even the first order goes to the PSC, the second order was ready for the CSC. Something like that was reported at most of the places. So unambiguous communication is critical. Charter of services. Again, you are working at the state, you are working at a district level. This charter is very crucial for the community. That should be there at the district level and the state level regarding various services available. Local customized solution using feedback. Again, this was missing in this COVID response. The feedback mechanism should be open from all the stakeholders, and that mechanism should be well sort of communicated in advance so that you can communicate and get the response and amend your response depending on the feedback. Then NCD services discussed in the review meeting during emergency. The responsibility of the program officer is, because most of the places, the CMO and the district magistrate, they are worried about more emergency services, the RCH driven services. The responsibility of state program officers and the district program officer is to include the NCD agenda in the review meetings, in the planning meeting at the district level. because district magistrate is not aware of the situation. So it is a responsibility of the program officers to tell them this is the, and you have to convince them using the data, right? Then and then this person get convinced, right? All bureaucrats need some data, need some rationale. So take this opportunity. Multi-sectoral coordination and data-driven policy at the state level and district level. Health facility level, again, at various health facility, shifting should be put up in the black and white. Who should will be doing what in the emergency situation. This is for the emergency situation as a part of advance preparing the plan. Provision of the supply, 3 months at least, provision of the supply should be there. Use of information technology has to be ensured for the health facility. Integration of the services. At most of the places, we have sort of a vertical program still running from the district downwards. So there is a mental health care separately. There is a program for elderly which is going separately. Then PCDCS अपना अलग से चलते रहता है. But to ensure at least at the district level, again, I will give example of Lucknow. They have the one place like this where all the programs related to the chronic diseases are happening. So, and so that you can leverage this program and you can sort of give the task shifting to these program officers. This is at the district level and the health facility level. Identification, engagement of private practitioner. Again, from the beginning in the plan itself, the role for private practitioner has to be listed. What they are supposed to do: consultation, referral, advocacy, communication. The role of private practitioner has to be ensured in our advanced planning from the health facility level. Then involvement of local medical association, again critical. The Indian state branch, the district branch of IMAs, the other associations which are there, leverage them in advocacy, providing services. And last, closure of the facilities should be discouraged, right? अपना जब war चल रहा है हम अपनी infantry थोड़ी बंद कर सकते हैं, right? So that has to be discouraged all the time. At the community level, the community participation and informal means of communication. Now we have various local mechanisms and support groups to ensure the communication that can be leveraged. Coming to the human resource, again, all program officers all the time they say that HR is the problem, right? HR is the key. So use this emergency response plan for as advocacy for your HR capacity fulfillment. Now you have the COVID, you have experience of the COVID. You can always say, always put up to the state program officers, to the district where your approving authorities that, okay, I have this emergency response plan. This is the HR. This HR I will require during emergency. So please consider this for filling up the vacancies. So take this as an opportunity, as a rational. Nobody will give you HR के ले लो भाई extra. कोई manpower extra कभी नहीं देता कहीं पे भी. You have to justify. So use this opportunity for emergency planning for that. One thing what we also observed that most of the places the district facility in charge were sort of toothless. They उनको कोई उनके पास कोई power ही नहीं था HR management का, HR delegation का. CSC level, PSC level, सब ऊपर से order आता था. So that has to be discouraged in emergency response. Whenever you prepare a plan, ये responsibility at this level है. CSC deputation has to be done by the CMO, the CSC in charge. The MS is responsible for the district level deputation for the management. That has to be completely spelled out in the plan. At the community level, seek volunteers, teachers, NGOs, welfare organizations, so that, and give them us again. Don't be generic in your communication or generic in writing your plan. Plan should be specific. ये NGO है, इस area में ये काम है. Teachers has to do this kind of stuff, right? That is a part of a preparation plan. Service provision, prioritization of the services during emergency is the key. So prioritize NCD services from the state to district level. That has to be there from the from top to bottom. Temporary upgradation of the facility. As I said, if the dialysis facilities, the daycare facilities has to be temporarily upgraded, that has to be preserved during the emergency. Charter of the response, again, for the health facility has to be ensured. Long-term provision of the medicines, then provision of the referral transport, again, key for the critical patients. Community level, communication with respect to the availability of the services at the community level is what we have found that they were not aware, even if the services were available. There was a generic sense that sab kuch band hai, kahan jaye. So communication from the ASHA should be there. using community survey for NCD, promotion, management, tracking, monitoring. So whatever opportunity is there, use that. Finances, reallocation of fund should be there, unrestricted flow. I don't think so. There is a finance issue. Again, I will say, as far as the health is concerned, we don't have the finance issue, more or less. There is an issue of the expenditure of the finance. If you do a good amount of expenditure, government is ready to give you whatever finance you require. Supply chain system, identify the suppliers, again important, who can provide you. And nowadays there is a GEM platform where you have to do supplies. There is a corporation who is provide the supply. So give them an emergency plan. Okay, this is our emergency plan. If something happens, this much stock we require. Give us a person sort of who can deliver the medicines, who can do the grievance redressal and all this. These are the small things, but important, that should be part of your emergency response plan. Local purchase, so state level program officer should give more hands, more leverage to the district level so that they can purchase. Buffer stock should be ensured. Expedited approval should be there. And doorstep delivery, as I said, is a key, especially for the NCDs. Use the local mechanism on the groups. The last slide. So way forward is what? Prioritizing NCD services during emergency situation in the both planning, because something which is not there in the planning will not come in the execution, right? So put your foot forward. NCD services are critical, and use data to support your claim always. You are all senior epidemiologists, use the services from the medical institute. I again say, align with your medical institute, medical colleges in your district, right? Take help of the community medicine department, faculty members, students, so that they will devise you the plan, they will give you the epidemiological data to support your plan. So which is put everything in the plan and then also in the execution. Preparation of the emergency catch-up plan, we should have the manpower task shifting, minimal interruption of the supply chain, earmark financial resources, and mechanism for intersectoral coordination. Mechanism should be laid out if something happens. So this is the chain of communication. This is the chain, how should we discuss? And last but not the least, we should always learn from others. It can be other state, it can be other district, it can be other facility, it can be other person. So take help for this document again when it will be public. Use this document, identify the good practices which are done in other states, and adopt it for your future response. Right? Thank you so much. Any questions? Any observations? Any experience you want to share? Yes. She, then you. Yes.
This was extremely helpful because we did these consultations earlier this year with Punjab and Maharashtra to see what was the disruption of services from different perspectives, from the perspective of the government, patients, CSOs. And CSOs really stepped up. We realized, like in Maharashtra, the Blue Circle Diabetes Foundation, they were linking people to Jan Aushadhis. They were conducting a lot of counseling sessions specifically targeting people with diabetes and how they should ensure care during the lockdown and pandemic. And similarly, we saw in Punjab, a lot of CSOs were stepping up, even working, say, with the police to help ensure medication supply. So I think even taking into account where you can tap into CSOs as a resources in times like this is very important.
Hello, sir. This is not a question, this is just my observation. So whatever we talked was related to pandemic preparedness. So something we expect in future. So we are treating them with fancy technologies, fancy drugs, but there is a way beyond the pandemic preparedness, that in the form of pandemic prevention. For example, you rightly said that the primary and secondary centers were existing only in design. Even the manpower was diverted to the tertiary care hospitals. So only if we have a baseline data of NCD patients, we can identify the priority groups rightly. Because I think that the tertiary care hospitals were burdened with patients who were comorbid, not under control. So since the primary care centers are not designed to, they're not having a baseline data, so the NCD patients are losing the routine care, as you rightly mentioned. But also the people who are not screened or who are not diagnosed lose both the routine care as well as the emergency care. So I think there should be a concept of pandemic prevention rather than preparedness.
Right. Any other observation? Ma'am. Ma'am.
So what was the time when you did this?
Last year, September, October. But it was recall also we have sought when we identified, when we interviewed the patient. And the records were also sought 2 years back. Like first wave, we tried to capture first wave and second wave, and also some catch up, as I mentioned before, how they sort of resume their services that we have. Right. Right, right.
Sir, I have just like, could you give an opportunity to capture the opportunistic speed that the COVID vaccination programs offered to the states? Because COVID vaccination started around about
January 2021.
And because the vaccination was primarily started for the senior people with comorbidities, COVID per se, I feel more morbid in those subjects. Because I belong to Orissa, and Orissa did a massive screening for diabetes and hypertension per se, in terms of COVID management and also in terms of the COVID vaccination. Everybody was being screened before they could be given the vaccine, and even after that. So this could be a good practice.
Absolutely.
So yeah, so this was a little observation. It doesn't see the COVID vaccination being mentioned in your data.
What I feel is communication was the key factor which was missing. It was all done haphazardly. चार इधर भेज दो, दो इधर भेज दो, and clustering was also not done properly during pandemic. Everyone was working except public health experts were not included in intersectoral coordination.
Right.
That's what I.
So as I said before, we should look this as a lesson learned rather than the problems identified. We also said to the ministry, we're going to submit the report, that we should don't, okay, jo ho gaya so ho gaya in a sense. But we have to learn a lesson, like communication, proper communication, using the opportunity of available services, be it vaccination, be it ARI surveillance for continuing NCT services, using your upgrading the existing health facilities, be it manpower, money, supplies that is there, using existing sectors, be it CSOs, be it private practitioners, NGOs, other welfare organizations, as a part of the response. So these are the basic takeaways I think we should focus on, and we should prepare for future emergencies. We should put it in a black and white that this is our plan at state level, district level, be it at a sort of block level, and specify the roles and responsibility of each person, roles and responsibility of each sector, and how we should do some sort of forecasting related to supplies, equipment. And also include this. I will again urge all of you to include this in your trainings. You're doing trainings of the district level medical officers, state level, other functionaries, all state program officers can include this part, NCD care provision in the emergency. Please include in your training one session or some sort of, if required, please we can provide the reference material or some customized presentation. Please include in your training. Any online queries, Dr. Abhishek? Not right now. Not right now. We can share the presentation in the print format. The report is pending for approval from the ministry. Once it is there, we'll share with all of you.
Sir, I have an observation. Like during 2021, I worked as a private practitioner for almost 1 year. So you mentioned about communication to private practitioner, but I feel it is very difficult because private market is very vast and they are very dispersed, like compared to government sector. And also there is some financial pressure for private practitioners because not all the private clinics are owned by the doctor. There are many clinics that are owned by the pharmacist, and there is some financial pressure to prescribe this format of drugs. So will they follow the protocol, and what are the strategies we can implement in the future to
In life,
combat this?
always seek for solutions. There will be a problem at each and every place. So there is a solution for everything. Private practitioners are also sort of, they are organized in some sort of association. What else? They do the CMEs, they have some local associations also. And obviously, to carrot and stick approach has to be followed as a manager, right? Give some incentive to them, give some, and communicate. Communication is the basic thing. If you acknowledge them, you okay, these many people helped us in response. That is good for most of the people. So, okay. Any questions on that? Okay.
Did you include that group into your this thing? Because I believe they were affected more with COVID and maybe they were dying also more.
So, yes, the fact remains that COVID affected everyone equally. The severity is more there among the comorbid patients. Comorbid patient is obviously.
Why I'm asking you because we had a dedicated COVID hospital. So sometimes any death within the premises usually used to be said COVID death. You know, like either spark the numbers or I don't know.
That is a different discussion altogether. We can have it over the tea, how to define a COVID death. Yes. We collected the data, but we haven't reported yet. It's a sensitive issue. Nobody wants to listen about the COVID deaths happening in the country. So we omitted that to avoid controversies.
My perceptions are based primarily from Orissa. Kota per se was one of the highest affected districts in COVID, but the one you selected, Kandhamar, low performing district. Obviously, there the services may not have been diversified to that extent. So that could have been a little, area of bias-based selection.
Absolutely. So we haven't factored in the COVID, I will say, burden in the district as such, because this was a dynamic situation. It was changing over a period of time. Ultimately, all districts were affected significantly. Few were known to us, few were not known to us. Right? 85% population in the country already got COVID. You know? So that obviously we acknowledge that we haven't factored in the COVID sort of burden or testing, whatever. There are indicators we could have included, but we haven't included that. We only included the programmatic indicators for NPCD scores as far as the choosing the districts.
Yes, there are no online.
One more thing, last thing, use data. We have a multiple data available at various places and we are not using it. Be it a COVID related, any program related, use data wisely, identify the people who can make sense of the data at various levels. So that is the key, right? Okay, thank you so much.
Next, we have a session by Dr. Umesh Kapil. Sir is Professor, Department of Epidemiology and Clinical Research in ILBS and former Professor and Head Department of Gastroenterology and Human Nutrition at AIIMS New Delhi. Sir is also Regional Counselor of Southeast Asia in International Epidemiology Association. Sir, you can take over.
Hello, good morning to all. Is my slides visible?
Sir, there are some issues. We will connect in Sir, if you can share your presentation, we can use it here on the display. Online participants are able to see your presentation, but offline are not able to, sir.
Okay, I'll do that. Oh, क्या मुश्किल है. I have sent my presentation. Have you received it? Share screen. Uh, God only knows how it works. Uh,
Are you unable to play?
no, no, it's
Share?
fine. So you are going to display the screen, huh?
No, no, sir. You will display the screen.
SharePoints, you are going to do it or I am going to do it?
You have to do, sir.
Okay, now am my slides are visible?
Yes, sir. It's visible.
Okay. It's good morning to all the colleagues working in the field of non-communicable diseases. Over the next 30 minutes, I'll try to tell
Sir,
you.
can you be a bit louder?
Okay. Uh, Good morning to all the participants. Is it better?
Yes, sir.
Yeah.
Thank you.
Okay. So, good morning to all the participants. First of all, my most sincere thanks to the organizers for giving me the opportunity to make this presentation. My special thanks to Dr. Anand, who have included this important topic in the NCD course, which is being undertaken by AIMS PGI collaboration, and this course is being run successfully, and this is the seventh year in which this course has been implemented. The topic I am going to discuss is prevention and control of non-alcoholic fatty liver disease. I'll just try to share what would be the outline of my presentation. I'll talk about what is non-alcoholic fatty liver disease, its magnitude, what are the risk factors, what are the strategies for prevention and control, methods of diagnosis, role of interventions like diet and exercise, and the future activities which are being undertaken to implement this particular program. Now, if you look at the magnitude of the non-alcoholic fatty liver disease, globally it is about 20 to 30%. In India, very few studies have been conducted, but it is in the range of 9 to 32%. If you look at the obesity, we have 30 to 90% cases in which some of the studies have been undertaken, and so is diabetes amongst the obese patients. Now, what is non-alcoholic fatty liver disease? It is essentially the deposition of fat in the liver, and when the fat is more than 5% in the liver, these hepatocytes, then it becomes non-alcoholic fatty liver. Now, from fatty liver, it because these hepatocytes are foreign cells, not the part of the liver, they are being rejected by the normal liver cells, and then it leads to inflammation. There is a deposition of fat, more deposition of fat, and this is what we call NASH, non-alcoholic steatohepatitis. Now, this is basically a progress from this to fatty liver to non-alcoholic steatohepatitis. Now, what happens is over a period of time, this is reversible. But however, 15 to 25% of NASH cases, they go into the later stages of what you call fibrosis of liver, and which leads to cirrhosis, and which leads to hepatocellular carcinoma. And this is, if you look at the US, the most important cause of liver transplantation is NAFLD related cirrhosis and its complications. Now, why it is so important for this particular course? Honestly speaking, for 40 years I was practicing public health specialist. I never heard the word of non-alcoholic fatty liver disease. Only when I joined about 4 years back the Institute of Liver and Biliary Sciences, I was given a mandate to initiate the non-alcoholic fatty liver disease into the non-communicable disease program of the country. And I am going to tell you that the story, how it began and how it was included. Now, if you look at the obesity is increasing in our country. This is a famous study conducted by Dr. D. Mohan Group, and this was supported by ICMR. And if you look at the prevalence of generalized obesity and abdominal obesity in urban area and rural area, it is a significant problem in our country. And if you look at the physical activity which are being undertaken in different states, is extremely poor. More than 90% of the subjects, they do not take any recreational physical activity. This is a very sad scenario, but this is the fact which was undertaken by the multicentric study which was conducted all over the country. Now, the issue is why we the Indians are more prone to suffer from obesity, diabetes, CAD. Why? It's essentially because we have a typical body composition, we have unique biochemical abnormalities, we do also have that our BM, for the same BMI, we have more fat in our body. And now this is what is happening is there are different theories which have come out, hypotheses which have come out, and one of the reasons what they say is we did have the peaks of starvation and multiple or excess of food. And hence what happened, we have developed the genetic composition by which we try to preserve food in our body. Now this is something all hypothesis, but if you look at for the same BMI, like this is a gentleman, Professor John, and we have this our dear friend Dr. Yajnik. He was visiting London, and then he got his MRI done. And if you look at, they both have almost similar BMI, but the percentage body fat with Professor John had was 9.1% or 9%, and Dr. Yajnik has 21%. Again, this was published in it's one of the milestone research investigations which has been published in Lancet, and they call it YY paradox. And for the same BMI, we have a higher body fat as compared to Hispanic population. Now, when we talk about the obesity, or we talk about we don't look at the a normal body weight person can also be obese, and this is a visceral fat which is present in his body. So don't think that all thin and lean people are non-obese. That's something important, and some studies have been conducted and which have documented that 5 to 16% of the subjects who may be lean, who may be having the BMI less than 23, but they have non-alcoholic steatohepatitis. This is something very important, and there are many factors which have been included for why this even the thin and lean people have this problem of fatty liver disease. Now, if you look at why this is very important, it is very important because because NAFLD is a high prevalence disease. It is a common cause of cirrhosis. It increases the mortality. The prospective studies have shown that patients who are suffering from NAFL, they have a higher mortality due to cardiac diseases, liver diseases, and cancer. Now, this is something we must remember. We don't have much data from our country, but the bottom line is it is the third most common cause of hepatocellular carcinoma in USA and first cause of liver transplantation in USA. Now, what happens is that most of the cases of non-communicable disease, we have the underlying cause is fat deposition in liver, that is NAFLD. Like we have there are hard evidence available through prospective studies that the patients who have NAFLD have a higher risk of type 2 diabetes, essential hypertension, cardiovascular disease, polycystic ovary, sleep apnea, cancers of breast, prostate, and colorectal. Even if you look at chronic kidney diseases and many other non-communicable diseases are associated with NAFLD. However, we do not have much evidence or not such a strong evidence on which comes first. These non-communicable diseases come first or the NAFLD come first. We don't have much evidence on this issue. Now, because of the association of non-communicable diseases there is a new term which has been initiated or which has been recommended in the year 2020, and they say that we should name it not NAFLD, but it should be MAFLD, that is metabolic associated fatty liver disease. There are many factors of the metabolic which are being associated with liver. Now I'll just briefly touch upon the prevention of NAFLD, and on 20 we initiated from ILBS with the blessings of Ministry of Health and Family Welfare this initiative. The guidelines were developed in which ILBS played an important role, and on 22nd February 2021 we were able to launch the national guidelines for implementation of NAFLD, that's a non-alcoholic fatty liver disease, into National Program for Control of Diabetes, Cardiovascular Disease and Stroke. Initially it was suggested that we should have an independent program of NAFLD because such a vast disease, but then it was taken the views of the public health people that an independent program may not survive, so we should include it as a part of NAFLD, NPCDCS. So we should have a part of cancer, diabetes, cardiovascular diseases, stroke, and this was included, and now it is in the national guidelines of NPCDCS. Now this is our Honorable Health Minister along with all the senior officers of the Ministry of Health. We included this, we released these guidelines, and these guidelines have been shared with all the states, all the program officers in the country, so that they can start including it into the NPCDCS program. Now, what are the risk factors for NAFLD? It's essentially the obesity, insulin resistance, diabetes type 2, all factors, all parameters of metabolic syndrome. There are some genetic factors, but we must remember that, at least I firmly believe, that the obesity is mother of all non-communicable diseases. So this is something important. Well, this is my perception, my scientific knowledge. Now, if you look at the risk factors for NAFLD, it is bypass surgery, polycystic ovary syndrome, sleep apnea, hypothyroidism, hypopituitarism, metabolic syndrome, hypercholesterolemia, obesity, diabetes, and these are the factors also for the CVD. So what is happening? There is an overlapping factor of metabolic syndrome, dyslipidemia, diabetes and obesity, which are important. Now when we look at how do we diagnose it? The unfortunate part is, or fortunate part is, that the NAFLD is asymptomatic, and most of the people, they are not aware about NAFLD. Quite a good number of obese people with abdominal obesity, they think that they are what you call suffering from NAFLD. But yes, there is a high chance or high risk of developing such individual to the NAFLD. But don't forget, thin and lean people can also have NAFLD. As I showed you earlier, 5 to 14% of the thin and lean people, they also suffer from NAFLD. Common symptoms are fatigue, sometimes pain in the right hypochondrium, but usually it is detected when ultrasound is being done or your LFT is being undertaken. Then they come to know that there is an abnormal LFT which is present. Now when we develop this, we put it into the program, we developed the bottom-up approach. We started with community health worker, primary health center, community health center, and district level. And this we have published in Lancet Gastroenterology. And I'll go into each and every these steps in next few minutes. So what happens is that India became the first country in the world that we have been able to include NAFLD into our non-communicable disease program, and this is also being replicated in different other developing countries because India is leading the developing countries on this issue. Now, the bottom-up approach is that Asha is our most peripheral worker. She is presently taking part and participating in the non-communicable disease program. She fills up the community-based beneficiary form, let's call it CBEC form, and we have been able to include our parameters like obesity, gallstone disease, the history of liver disease in the CBEC form. These CBEC forms are submitted to the ANM or healthcare worker. She validates these forms, parameters which have been referred by the ASHA. This is not only for the NAFLD but all other non-communicable disease. This is beyond the purview of this present lecture. What are different parameters are being filled in the CBEC form. These patients, these healthcare workers refer to the medical officer, and medical officer validates the forms. He identifies the patient with deranged LFTs. He further identifies the subjects who are high risk for the PSA. Now, at these three levels, it's a primary the screening program which is working. When it comes down to the secondary care level, so what happens is it is expected at the community health center we should and we may have the ultrasound machine, and here what can be done is the patient can be subjected to ultrasound and then his liver fibrosis can be assessed, or what can be done is the LFT and complete blood count can be undertaken, and if these two tests are available, we can calculate the NAFLD score and FIB-4 score. These are two scores which are non-invasive in character. We can just by taking the blood, we have the formulas available, we have the data on specificity, sensitivity, negative and positive predictive value, which can tell us that whether the patient has NAFLD or not. And then we can talk about the subjects who have a low risk of fibrosis. These patients are referred back to the PSC for the management of diabetes, dyslipidemia, hypertension, weight reduction, and reassessed after 3 years. The second group is indeterminate risk. Now we are not sure about with the formula which we apply to these LFT and CBC whether these patients truly have NAFLD. These are sent to the district hospital, and if you look at the third part, which can be immediately diagnosed, yes, these patients suffer from advanced fibrosis. So what we can do that we can refer them to district hospital. Now, I must admit over here, when we developed these guidelines, the patients of the NAFLD were treated at the district centers, district hospitals, because district hospitals do have the specialists, and medical specialists are working there for long time, and their clinical expertise, they were treating these patients. However, the flow of the patient from the community to them was restricted because of unawareness and because of certain other constraints. Now, these are the non-invasive parameters of NAFLD fibrosis score, and if you look at, it has a high negative predictive value. So they are able to diagnose, they are able to give us the useful information that what is whether the patient have uh, liver fibrosis or not. These are the interpretations which are required. AST is a part of the LFT. Similarly, we do have platelet count as a part of LFT, and by this formula, and what we are planning to do or what is being done is we are giving them a software, an app in which the patient's age can be put in, AST can be done, platelet count can be done, and then we can calculate the FIB-4. Now, this is a simple thing which it's a beginning. And we don't take that within a 1 year or 2 year it will be implemented in the entire country. It will take time. Country is such a vast, and we are in different stages of health program implementation in our country. And same is true for the NAFLD. We are developing a app. Not we means the Government of India, Ministry of Health and Family Welfare is developing an app so that we are able to diagnose the advanced fibrosis, advanced or no fibrosis amongst them. Now, once the patient reaches the district hospital, and those who have the indeterminate risk or who have the advanced fibrosis, here the patient can be referred. Again, this is in very initial stages. The patient can be referred for fibroscan. Very few fibroscan machines are available at the district level. Yes, we are planning, or government is planning to have in public-private partnership, these machine can be installed at the district places, so the government doesn't have to bother about its maintenance and cost and so many other things. And then we look at once the fibroscan is being done or ultrasound is being done, we do have the risk of advanced fibrosis high or low. Low risk patients are referred back to the PSC to be reassessed after 3 years, and high risk patients are referred to the tertiary care hospitals, that's the medical colleges or regional hospitals in our country. We have utilized the existing system. No separate cadre has been developed for prevention and control of NAFLD. Now, at the tertiary care level, we do have specialized evaluation services. We have gastroenterologists, hepatologists, medical specialists. They undertake the fibroscan. If possible, they also undertake the liver biopsy and then evaluate the patient and do the management. They evaluate, manage, they start the treatment and send it back to the district, to the community health center and the primary health center, because we do not have so many beds available by which we can admit all the cases of NAFLD, advanced NAFLD disease. Now, what are the interventions? Interventions, if you look at, there is no drug available. It's in a very primary stage that drugs are available. So the primary two interventions are, or the most important intervention is the way to reduce weight. And all the program in the country, if you look at Fit India, Swasth India, all programs which we have in our country are aimed towards increasing the physical activities, consuming the healthy diet. So what we need to do is physical activities and dietary intake should be modified to reduce the body weight. Now, what has been seen that if we have the NAFLD, that is reversible, we should be able to reduce the weight by about 5%. If we have NASH, then 7 to 10%. If we have NAFLD cirrhosis, 5 to 7%. And these are some of the steps which are known globally, that no snacks, regular meals, reduce sugar, fructose, sweetened beverages, refined carbohydrates and processed food. Consider intermittent fasting, consider Mediterranean diet, or minimize the intake of alcohol. And similarly, we do have, these are each of these interventions which have been listed over here can have a complete lecture. Now, what has been seen is, what is the evidence? The evidence is that if we undertake in steatohepatitis resolution, we have, if we reduce weight by 5%, this is the impact which we see. If we look at the so what will happen if we have 10% reduction in the body weight? We see this type of reduction. So what is important is that if we are able to take care of fibrosis resolution or regression, we are successful. This is very important intervention. So that means the weight loss by the patient is most important in management of NAFLD. What is a systematic review and meta-analysis? They show that more than 5% weight loss leads to improvement in steatosis stage. Large prospective studies have shown that if there is a reduction of weight loss by more than 10%, there is a 90% resolution in cases of NASH and 45% resolution or regression of fibrosis. This is something very important. So one of the most important intervention is to reduce the weight. RCTs have shown 64% of the patients in the intervention group achieved remission of NAFLD. 97% of the subjects with weight loss of more than 10% has remission. Now we do have a program, a big project in the Delhi, in which we are taking the school children with NAFLD and without NAFLD and doing an RCT by giving the intervention of physical activity and dietary modification and look at the improvement. From our country, there are not many studies have been done. Now, what is the ideal body weight? Is suppose my height is 170 centimeter, I should minus 100 from that, it should be about 70 kg. Now this is something important. This is just a very approximate way of calculating what should be your ideal body weight. Now this is what we have been giving it to the Ashas so that they are able to do it. For women we do height minus 100, then minus 5%, and then it makes the, for a female, suppose a female has 160 centimeter height, it should be about 57 kg weight. Now, as I mentioned to you, for dietary approaches, lifestyle approaches, is a calorie restriction and fructose intake. Now what is happening, this fructose is basically a problematic in our daily life. We take the fruit juice, we take the colas, this is something which has been a major problem which I as a person working in the field of public health nutrition feel. Daily intake of alcohol, it should not be done. It should not be done. We should undertake the physical activities so that we are able to reduce weight. Now, decreasing the caloric intake by approximately 1,750 to 1,000 kilocalories, we may reduce the weight we can improve the insulin resistance. Now, this is something important, and several diets have been tested that to reduce the body weight, and it's a difficult area we are in. But what is being said that if we take the Mediterranean diet, it might help in reduction of the hepatic steatosis. And what is Mediterranean diet? I personally feel as a public health person, you just have some idea about it. No need to going it, but all diets which are there, they talk about more intake of green leafy vegetables, fruits. They talk about the less of red meat and processed meat, and moderate intake of seafood, poultry, and such. This is a Mediterranean diet, but it's so difficult to maintain it. Now, this is something again we must remember this. Keep these slides with you, and if you have any questions, please you can write it to me. Now, even that exercise, when we talk about of moderate intensity, it should be able to increase the heart rate, it should be able to increase the rate of breathing. That is most important. And we should do it for half an hour to 60 minutes, at least 3 to 5 days a week. I am sure that some of the colleagues must be doing it. Now, sleep, stress, and smoking. Uh, Inadequate sleep negatively impacts insulin regulation. Ultimately, it leads to diabetes and IFG. Stress can lead to obesity. We sometimes, most of the people, or quite a good number of people, when they are under stress, they want to eat high carbohydrate or uh, sweet things so that they can overcome their stress. Smokers have to see that there is an increased severity and incidence of NAFLD in them, and there is a nicotine mediated oxidative stress which leads to hepatic lipogenesis. Now, this is what I talked about the prevention and control. The last is that unless until we give orientation to our health functionaries at different levels about the NAFLD and its program implementation, will not be able to achieve it. So, in the guidelines which we have, operational guidelines which we have been released by the Government of India, they have made a cascade model of training. The master trainers would be at the NCD cell, National Institute of Health and Family Welfare, and training institute would be DGHS, ILBS, NIHFW, National Health Service Resource Center. So these would be training a different level of people at the national level. The national level would train the medical college level would train the clinicians in different management, district level, CSC level, PSC level, uh, MPWs, and at the community level. This is a cascade model of training which has been developed, and they're going to go about it and train everyone. So we do have this important training component under the program. So I'll summarize my presentation by mentioning that NAFLD is a accumulation of fat, subsequently leading to inflammation, leading to fibrosis, cirrhosis, and hepatocellular carcinoma, leading to the liver transplantation. The magnitude is very high. Fatty liver is the core of all non-communicable diseases. Calorie are recommended. Both of fats and carbohydrates should be reduced, fructose particularly. Coffee and vitamin D may have a protective role. This has also been some evidence is available. Avoid alcohol, and diet. Which should be the diet? I personally feel dal roti khao, season के fruits खाओ, vegetables खाओ, और exercise करो. That is the diet which is important for all diseases. With this, I conclude my session. Thank you very much for patient listening. And I again like to thank Dr. Anand for this invite and giving me this opportunity to share this new area for quite a good number of people who are not aware about NAFLD. Thank you very much. Thanks a lot.
Thank you, sir, for guiding us to prevention and control of NAFLD. Sir, we are running a short of time. So if there are any questions, sir, we will write in mail and we can get it follow up from you.
Sure, sir. Thank you very much, sir. Thank you.
Thank you, sir. Session is by Dr. Anand Krishnan, sir.
Now we move into the next session, which is on surveillance. And as the bottom line says, what gets measured gets done. We all want to know how much progress we are making, right? We have largely talked the last 3 days about what we can do. Today, in this session, we will talk about we need to monitor them, see how well we are doing or how bad we are doing, depending upon how you look at it. And therefore, the strategies will then depend on that. If you are doing well, then we should continue. If you are not doing well, we need to rethink our strategy. So, to do that, we need to have a surveillance system in place, right? We all are generally aware of communicable disease surveillance, which is relatively easy to define. We generally we just count the number of cases. That's the basic thing in communicable disease surveillance, right? We look at number of cases, whether it is TB or malaria. Obviously, there are other indicators, including program indicators. So, in NCDs, what do we count? So, what do you want to count? Is disease counting, for example, is the way to do like we do for communicable diseases. Should we do the same for non-communicable diseases? Count number of people with diabetes, with whatever mental disorders, with cancers, etc. And how do we get that number if you want to, right? Do you want to get people who with disease who come to hospitals? There may be many. We saw in examples of hypertension and diabetes that many don't come to the hospital also. So how do we count if we want to count NCDs? So obviously, any surveillance system, first thing you have to be clear is what is it that you want to measure, right? That's the first thing in any surveillance system. What is it that you want to monitor performance? We also want to do a lot of things, but a surveillance system has to have a priority, a focus. We cannot measure everything we want. No system can afford to measure everything. So we have to prioritize. We have to find out which are better things to measure. So based on general understanding, and we will take each of them separately, this is the framework that WHO recommends for surveillance. It looks at 3 things: outcomes, exposures, and health system response or national system response. There are 3 broad domains in which we measure things for NCDs. The first is outcome, which is disease-related morbidity and mortality. Right? That's the first thing. That's quite similar to what we do for communicable disease. Right? The second, which is not generally seen in communicable disease, is the exposure or risk factor surveillance, largely looking at behavioral, metabolic, as well as social determinants. Again, social determinants is across any surveillance system. And third is national system response. How are countries responding to NCDs? What are you doing? How well are you doing? So that we modify our strategies, which includes access to key healthcare interventions, health system capacity, and other legislations and those kind of things. We'll now take each one of them and go through them and understand why and what kind of indicators are there. So obviously, to do any surveillance, you need to have standard tools, standard definitions, standard measurements, right? Especially if you want to compare over a period of time, compare between states, compare between countries, we need to have standard tools and definitions for any surveillance, right? So these have been defined. Some of the examples I'm giving you, like for example, mortality, because largely in most countries of the world, we do not have a good medical certification of systems. Most important source of death across the globe is a verbal autopsy based systems. So WHO has a short list of, WHO tool is there for verbal autopsy. There is a short cause of death list, which enables you to put those, use the VA tool to identify the causes. In morbidities, obviously, depending upon prevalence or incidence, you can use disease surveys and registry. Risk factors, we have WHO step surveys. And for health system readiness, what we have service availability and readiness assessment, typically called as SARA assessment tools. And for global, for many of the policy things, we use what is called as global NCD capacity assessment survey. This is a survey which WHO conducts where countries report. Do we have a policy for unsaturated fats? Do we have a policy for whatever, or what is our tobacco control policies? Based on that, WHO compiles. So this is how we both nationally and globally monitor progress. Now we'll start with mortality. What are the advantages and disadvantages of mortality surveillance for NCDs? Anybody wants to say? Yeah, this is especially true for NCDs where you can have multiple morbidities. But ultimately, even for medical certification, you have to put only one cause of death, right? Most mortality surveillance, you have to end up with one underlying cause of death, which is what is used for analysis.
But sometimes it happens like there is not enough information. For example, even in Minerva, there is a category called R99, where there is
especially more so in a verbal autopsy based system, we don't know cause of death in many of the times. We are unable to give a specific code. We end up giving a non-specific code. That is true. But those are operational issues. Is theoretically mortality a good indicator for NCD surveillance? Remember, our aim is always to reduce whatever, especially morbidity and mortality, our aim is to reduce. So do you think a good surveillance system will be able to prove that the mortality is decreasing, right? Yeah, okay, good.
I think mortality would not be available. If one day somebody will die,
Yeah.
at times the diet
Yeah. Okay, good point. So two things about that. First is obviously that is a good thing because it is the ultimate impact of any disease is in terms of mortality. That's a good part of it. And people understand. If you tell so many people, it is the easiest thing. Risk factors and all, people may or may not understand that. But number of deaths is easy to convey to policymakers and everybody, right? Disadvantages, it takes too long to change it. You don't expect any change in mortality within few years of any intervention, unless they are, for example, MI management and those kind of things, right? Most of our interventions of health system strengthening will result in a mortality reduction in maybe 5 years, 10 years time. So it's not a good sensitive indicator of a change, right? The other thing is that ultimately everybody has to die, and proportion of NCDs is actually a function of how much we control communicable disease. It is not a function of how well we are doing in non-communicable disease. If you control communicable disease, everybody is going to die of non-communicable disease. There is no other way to die, right? Apart from injuries. Injuries largely remain constant around 10% if you see globally. Therefore, it is not a good measure to assess effectiveness of your intervention. The second point, other point made by her is that our aim as far as mortality is concerned is to postpone mortality. Therefore, proportion of deaths due to NCDs is not a good indicator. proportion of premature deaths due to NCDs is a reasonably good indicator. After, and we have defined premature as below 70 years of age. That's the way that WHO has defined 69 years and below. So our aim is to postpone deaths to above 16 years. Then more you postpone, better. But definitely early deaths, premature deaths are to be avoided. So premature death is a better indicator than any death. And we know, I will not go into details about the systems because
Here.
Yeah.
But as per the policy front is considered, the mortality indicator is the best indicator for deriving any policies, I feel.
That I already told that that's something that policymakers like. But it is also our job to educate them. No? So it goes two ways. We have to satisfy them also, we have to educate them also. So we have to use all opportunities of interaction to do both. But as I said myself, that it is policymakers get convinced, but you have to convince them it is not a good indicator. Nothing is going to happen in short term.
Yes.
And everybody is going to die of NCDs only. We cannot prevent it, especially as we age as a society, which we are going to age. That's something that we want the society to, right? All of us survive longer. More and more people are going to die of NCDs. So that's not a good indicator. Ultimately, policymakers also want to show a change, good change. So we convince that it's a bad indicator to show change. They will, I'm sure, get convinced. But there are a lot of problems about how we collect data on mortality, right? India's mortality surveillance system is not good, especially medical certification hardly covers 20% of deaths. And the only good source is the SRS-based verbal autopsy, which covers only 50,000 deaths in the country. Representative, but a smaller number, right? So we obviously need to improve mortality surveillance in the country, but I'm not getting into that as a part of this system. The other thing is about the morbidity. What do we do? How do we do disease surveillance for NCDs? We can either, morbidity can be measured as a prevalence or as an incidence, right? Prevalence, mein kya problem hai? First is that they all need a disease survey. Nationally representative disease surveys are going to be very costly. And you want to do it repeatedly, then only it's surveillance. Survey is one-time survey is not surveillance. So it is, and diagnosing them are not that easy. If you have to do a heart disease surveillance or a respiratory disease surveillance, and these diseases can be many more. It is going to be a very costly way to do surveillance, right? The other thing to understand about what will happen to prevalence if your programs are effective. Will it go down? Will it go up? Why will it go up? Sorry? Screening will not impact prevalence. I will come to that later. Huh? Why? Yeah, because you are going to, more people are going to survive. If your interventions are effective, people with diabetes will survive longer, or hypertension or a heart disease. They all will survive longer, right? That is our whole intention of intervention. If we are effective, they all will survive longer. If they survive longer, prevalence increase. Prevalence is a function of incidence into duration. So prevalence will increase. It's not a good indicator. You will say, oh, prevalence of badra, I am not doing a bad job. It's not a good indicator, right? Screening will not increase prevalence because prevalence we measure everybody. So even screening only gets those already diseased are picked up. So prevalence will not increase because of screening, right? Therefore, incidence is a better indicator than prevalence, but measuring incidence is all the more difficult, right? The only way that we measure incidence in NCD context is when we do disease registries, especially population-based disease registries are the ones that are used to measure incidence of disease. But disease registries are also quite complex systems and quite costly systems. It's not that easy to build registries. So as you can see, this is the data from verbal autopsy and which we discussed. The point that he made, you can see almost 15% are ill-defined conditions. Most of them would be in the NCD category, most of them, right? So that's the problem with verbal autopsy based system. So if you look at globally disease registries, cancer registry is the most common disease registry, which is there, so you can look at the chart, the upper one tells you about cancer registries, with the orange one being the population based registries. Obviously hospital based registries are relatively easy to built. Population based means that you have a population denominator. To calculate incidence, you need a population denominator. Hospital based registries don't give incidence. They are good for telling you how much survival, outcomes. Those kind of things are good from hospital based registry. But if you want incidence, you have to have a population base. That is much more difficult, but it can be done. If you see the below, that is tells you about diabetes registries, which is happening across. That's the next disease for which there are also now stroke registries. Many registries are happening. Many of them are hospital based, but over a period of time, they will spread to have a population base. So again, as you can see, that population based diabetes registry is quite uncommon. Mainly it is hospital based registries because of problems involved. Even if in diabetes, many people have started doing young diabetes registries because that is much easier to measure. With diabetes prevalence so high, incidence will have, you have a lot of patients on that. Whereas young diabetes registry is also there in India. ICMR has now started many disease registries. And if you have more questions, my next speaker, Prashant Mothar, heads all the disease registries. So you can have questions on the disease registries, you can ask him. Now we come to, so we have done with morbidity. Now we talk about risk factors. Again, I will not go into the detail. We all know what are those risk factors. We have been talking about them repeatedly. Risk factors are good because they are where you are going to intervene, and they are one which are going to change really fast. Yes, smoking, anti-tobacco can result in change within few years. You don't need many years to show a change. Similarly, if you have good, especially higher level interventions, policy, legislation, they have almost immediate impact. You don't need any behavior change. You might need much more time, but policy level impacts are pretty fast to occur. So risk factors are good because they are easy to measure. We can measure alcohol use, diet, physical activity relatively easier as compared to disease. They are much quicker to show an impact. So we prefer risk factors as a primary mode for NCD surveillance. You measure NCD risk factors and that shows the. But the opposite is that NCD policy makers don't like. Okay, behavior has changed, but by disease ko kya hua? Disease bada ki kam hua? That is what policymakers would like to know, because risk factor is seen as is a mediatory parameter, not necessarily the outcome parameter, right? So people don't get convinced, and risk factor interventions are also very complex interventions, which we have been trying to see. So ultimately, we need to do nationally representative NCD risk factor surveys, right? Using a standard tool which WHO has provided, which you can adapt, which is called as the STEP surveys, where step 1 is behavioral, step 2 is anthropometric, and step 3 is biochemical. And depending upon your resources available, technology available, you can do all the 3 steps, you can do 2 steps, you can do 1 step. That's the countries can choose. So I'm not going to too much detail of this steps. You can easily look into this. In India, in fact, I was the first one to be trained in WHO steps way back in 2000. 2003 in India, we conducted the first step surveys. Then ICMR did, and then now obviously we have done many more such surveys. So if you look at globally, you can see that if you look at bulk of risk factors, most of them are pink, which is good, especially in Southeast Asia region, seems to have been doing the best in terms of step risk factor surveys, right? And to some extent, I think credit must go to me because I have been participating in Nepal, in Sri Lanka, in Myanmar, in Timor-Leste. Many of those surveys have gone there for training and other things. So Sierra is clearly doing the best in terms of doing a risk factor surveys. Next, coming to national system response. You can ask me any question at any time you want. We don't have time to go into details of this, so I'm just providing you the framework. So we also want to see how countries are responding to NCDs. We want to measure countries' response, right? So they are largely process indicators. They are not obviously outcome indicators. It should include both health and non-health. And they are quick. It's a more or less, you ask the policymaker, yes, no, these are much easier to measure, except health system response, right? For example, how well have we strengthened health system, which is by what I told earlier, by service availability and readiness. How much equipped are our health system to manage NCDs, right? Or how many health facilities have, for example, blood pressure apparatus, or a peak flow meter, or metformin, insulin. So by looking at availability of key technologies and medicines, we will know how much our health facilities are equipped to manage NCDs. That is called as a service availability readiness assessment. We need not necessarily measure everything, because otherwise the list of medicines will be 100 odd. So many NCDs are there. So we use what is called as a tracer diseases and tracer indicators. We use some key major core important medicines and then look at their availability. It will not have exhaustive list of indicators. The issue with that would be in countries like India is how do we measure private sector, right? The bulk of our health system is provision is through private sector. Most of these assessments only look at public sector facilities. Private sector facilities is not easy to look. They may not even allow you to come and see, right? So there are issues with national system response. So again, if you look at these countries which have done, so almost again, CRO seems to be pretty good, but just remember that CRO has only 11 countries. Most other regions have much bigger number of countries. So the denominator is much bigger. In actual number of countries, it will be smaller. Our numbers are smaller. So in terms of countries, CRO is the smallest. Okay. So there we talked about the systems. Now we talk about indicators. Right? What indicators should you use? Some of them are, for example, I discussed prevalence, incidence, age, what age we should take. Those kind of things are ultimately we need to, for monitoring, we need to have indicators, right? So WHO has again a set of indicators, 25 indicators. Yeah. They are good indicators. They are generally also covered in the risk factor. Step surveys also covers adherence. It goes beyond risk factors today nowadays. So if you look at STEP questionnaire, it asks questions about risk factors, but also people with disease, it also asks about where they get treatment. Did they take medicine in last 2 weeks? So it also measures adherence as a part of the STEP surveys. It is important to measure adherence in NCD context. So based on different criteria, WHO has identified 25 indicators across these 3 domains: health system, risk factor, exposures, and mortality. I'm not going to talk about all those 25. And only 9 of them it indicated targets. So WHO framework talks about 25 indicators and 9 targets. And we'll discuss the targets in detail. Obviously, ease of collection of data has to be there. You cannot have a theoretically very good indicator, but we don't have any system to collect those information. That is why, for example, in the incidence, in the morbidity, there is only one indicator, which is on cancer incidence, because that's the only thing that is globally applicable. There is no point. Most countries don't have any other information. So then we set a target for many of these indicators, right? Globally, it was set, and then India set its own, and we'll discuss about that. So we are clear that out of 25, only 9 we have targets set. They were based on global available evidence, how much we expect. Some of them, it was slightly ambitious. For all the targets are relative to 2010 levels. So when we say reduction of tobacco by 30%, we mean that with as 2010 as a baseline, whatever was prevalence of tobacco use was at 2010, at 2025, it should be less than 30%. So there is no same number for all the countries. All countries will depend on how much they were in 2010. If India was 30% in 2010, it will go down by 30%, which is about 9%, right? So it should reach 21. Similarly, some other country might be in 10, it will reduce by 30%, so it will reach 7. So that overall reduction is by 30%. And interim monitoring will occur in 2015 and 2020. This was before SDG was set. Obviously, with SDG, we also have now 2030 as an indicator. So now I'm going to only discuss in detail about the targets. First target is the mortality, and the target only focuses on premature mortality. It does not include mortality. That's because of the reason that we discussed, right? The indicator is unconditional probability of dying between ages 30 to 70 from these 4 major NCDs. If any of you is knows about the life table approach for survival, then conditional probability is exactly the same. If 1,000 people enter or 10,000 people enter 30 years, at the rate of current age specific death rates, what is the probability that they would die by year 70? That is what this measures, right? And we expect it to be down by 25%. India's baseline was around 23%, right? And currently it is 21%. We have gone down slightly, not doing very well, but not doing very badly either. As I said, for the morbidity, we have no target set. There's only one indicator and there is no target set. So now we go to risk factors. So the alcohol, the target is 10% relative reduction in harmful use of alcohol. Okay. There are actually 3 indicators of alcohol. Target has been set for only one, which is the second one. There's also 2 other indicators on per capita alcohol consumption and alcohol-related morbidity and mortality, but the target has been set for only harmful use of alcohol. You remember yesterday, Dr. Ambekar also told you they have to differentiate between harmful use and use of alcohol, right? So this focuses only on harmful use of alcohol. India's monitoring indicator, if you look carefully, it removes the harmful use. It says 10% reduction in alcohol use, right? So India has slightly deviated in this indicator, in the sense of Indian indicator does not have harmful use of alcohol. India was the first country to set its national targets. May 2013, WHO set. June 2013, we had a meeting in Mashobra, where many of us were there. Then the target was set. There was strong this thing that we should not talk of harmful use of alcohol. We should reduce alcohol. So anyhow, that's the doctors have ambivalent this thing about alcohol, right? Messaging. Some alcohol is okay. Too much alcohol is bad. That's initially WHO also used to do the same thing, but now WHO is moving towards no alcohol. Recent, if you see its communication, it's focusing more on non-use of alcohol. That is the point I was making. We are using that to say that some alcohol is good, but as a public health, the message should be to avoid alcohol. Okay, the other indicators of physical activity, you can see we are not expecting big changes. 10% reduction over 15 years from 2020 to 25 are actually not that big changes, right? Though these are difficult areas, but they are not that difficult, right? So the targets have been set with some reasonable data of what can be done. So again, this physical activity indicators is both for adult and separately for adolescents. So there are 2 indicators, one for adult, one for adolescent. We have set target only for adults of 10% relative reduction. Then is sodium intake, 30% relative reduction, right? And for adults. So the problem here is how to measure sodium intake, right? How are we measuring sodium intake as a part of surveillance? Anybody knows how we measure sodium intake? Yeah, so it's done by 24. Actually, it's quite complicated. It is by urine sodium estimation. like we do for iodine, similar approach. And we use a spot urine sample and estimate 24-hour, and we collect 24-hour urine sample. So everybody, if to do this, you have to collect 24-hour urinary sample to assess how much urine output is there, volume. Then multiply by the sodium concentration in that urine, you will get 24-hour urinary output, right? It is quite complicated. It is very difficult to do. That's why many countries are not doing. And you need to have an equation to convert it. There are multiple equations available. There's a Kawasaki, Tanaka, Intersalt. There are multiple equations where you put your BMI, this, and then it gives you an estimation. So it's a bit complicated process. Those equations, there are some people question. In fact, we have done a study where we looked at these equations. Not all of them do really well. In some places, Kawasaki does some better, some places Intersalt. Ultimately, in India, we chose to use Intersalt, but there are problems. I just reviewed a paper from Bangladesh where they said Kawasaki was giving a better performance than this. So there is a lot of, each of them very bit here and there. So there is this a problem. Even in the National NCD Monitoring Survey, we only did it in a subsample. Even though we did 12,000 adults, we only did it in about 3,000 people. So because it is much more, we have to visit the house twice, give them a big can so that they collect urine, then go the next day, then collect the this back and those kind of things. It's very complicated. It's not easy to do. But for hypertension, perhaps this is the most important indicator. It also has implications, just to tell you, that most intervention for salt reduction globally is they are focusing on processed food, right? Reducing. That is not very appropriate in the Indian context because our population's processed food is not that much. Actually most of salt comes from salt that we put during cooking. Therefore, our effort is much more effort is needed. Western countries will solve this problem by reducing, because most of their salt comes from processed food. So reduce salt in processed food, your salt intake of the population goes down. In India, it is not going to work. We have much harder way ahead of us to decrease salt intake, because all of us are very fond of salt. If we reduce salt, none of us like. Currently, India is consuming about 9 grams of salt as per our survey. So 5 is long way to go for us to reach population average of 5 grams per cent. Tobacco use, again, this is easy. Again, we have 2 for both adolescents and adult. Adult has a target of 30% reduction. Again, this is much easily doable. India is roughly on target. If you compare GATS 1 and GATS 2, we are currently in the process of doing GATS 3. It should happen this year. We are just discussing the protocol and those kind of things. IIPS is going to conduct this survey. So we will know, but largely between GATS 1 and GATS 2, we are doing reasonably well. So hopefully the problem now is more of, as I said, oral tobacco and bees. Cigarette use has definitely come down in a big way. The other 2 are still a challenge. Raised blood pressure reduction, then again by 2 step surveys, our target is 25% for adults. Diabetes and obesity. So world did not expect to make much change in diabetes and obesity till 2025. Therefore, the target is let it not increase. Coming down to possibly near, because no country in the world has actually shown a decrease in diabetes or obesity. So at this point of time, we could not keep a target of decreasing it. So at this point of time, the target is, even if after 2010 it goes up, by 2025 it should come down to where we were in 2010. It does not mean that you should stay at 2010. That may not be possible. But you can go up and come down by 2025. Again, this is for both, obesity is for both adult and adolescents. Diabetes is only for adults. Then there are 2 targets which are health system related. Right? Risk factors is over. Now we go to targets related to health system targets. There is no relative targets. They are absolute targets. Right? So first is related to people receiving drug therapy and counseling. So if you know CVD risk assessment, people who have high CVD risk, at least 50% of them should be on prophylactic treatment, either statin or aspirin, or if they're diabetic, glycemic control. So there is no baseline for it. This is an absolute target. By 2025, we should reach 50%. The other is on health system. How, as I said, what proportion of your facilities, primary care facilities, have basic technologies and medicines for NCDs. Basic technologies has been defined by NCD as a part of PEN package, which we are discussing. And 80% of facilities should have. Right. And I think Prashant will speak more on this because this talk is on health system preparedness. They are not doing very well, as our recent survey shows. It is less than 10% in most of the in the survey that we did in 2017-18, including in districts where NPCDs was being implemented. So we look at 3 reviews. We are actually crossed 2015-2020. It is also now part of SDGs. So quickly to finish. So for example, tobacco, we made a target of 30% because we looked at the different interventions, how effective they have been, and then put it as a part of this thing. So these decreases are based on modeling and those kind of things. And unless, but if we don't do, what we are currently doing, we are not going to achieve the global targets. We need to do much more than what we are doing. This is the Indian framework. The only difference would be one is in alcohol. As you can see, it says relative reduction in alcohol use, right? That's the one difference. The other is the addition of the 10th indicator, which is on household indoor air pollution. This indicator is there only for Southeast Asia region. All other countries in this region have also. The only region and which has household indoor air pollution as a target is Southeast Asia region. And we want to reduce it by 50% of households which use solid fuel as a primary source. So just ending, obviously you need to have different sources. As you can see, there are so many indicators, you have different sources. In India, there are so many sources for NCDs that there is a lot of confusion. Should we go by GATT? Should we go by NFHS? Should we go by, even used to have adult health surveys, National Nutrition Monitoring Bureau surveys. Ultimately, we decided that we should have one survey which answers all the indicators. And we went for National NCD Monitoring Survey. This survey was done by AIMS and the NCDIR, Dr. Prashant Mathur's team. And we did a national level survey, covered adults, adolescents, health facilities, all the indicators that you want has been covered. Its report is available on their website, so I'm not going to show you the results. It was funded by the ministry, so which is a good thing. So this tells you what are the different targets, indicators, and what are the systems which are available. So there is a framework. Also Dr. Thakur said that this should also occur at state level. But states are not doing that. So that's my message to people with the state program managers here. Think of doing a monitoring at state level. Each of the state program managers can go. Our team at AIMS or NCDR can provide whatever technical support is required to conduct such surveys and monitor state level performance. If you monitor state level performance, monitoring national level becomes much easier, right? The numbers will be bigger also. So that's my message for all the people here. Let us also start monitoring at state level, because ultimately health is a state subject. Many interventions can occur at, many initiatives are occurring, like in Telangana. There are many initiatives occurring at state level. Why should we not monitor things at state level? So that's all. Thank you.
Thank you, sir, for guiding us through approaches to NCD surveillances. Any questions?
Sir, according to the National Action Plan, by 2025, we have these objectives like we need to reduce the 30% of sodium or salt consumption. So there is gaps identified in that, according to whatever we are talking now. This session, what you have taken, I can understand there are lots of gaps in that. 25% reduction in mortality can be achieved, and then 25% reduction in the prevalence of high blood pressure can be achieved. Then what about this 30% of salt consumption? Any interventions for that?
So there is the discussions occurring. See, as I said, salt monitoring itself happened much later than risk factors. Salt was one of the last risk factors that we had some national data. Even that, so sample size of only 3,000. So we are not measuring salt intake very well. But now some talks are going on to especially on high, again more on processed food. But as I said, they may or may not be very effective in the Indian context.
Yes.
We need a behavior change at cooking level, at household level. That level of intervention is not happening. And it will take much more effort than what we are doing to achieve the salt targets.
So can we achieve our targets with this?
It's a complex mix. We don't know. We will do good in some, we will do bad in some. Ultimately, how much impact it will have mortality is difficult to predict at this stage.
Okay, thank you.
Sir, I would like to make 3 points here, sir. Sir, under our National Tuberculosis Elimination Program, there is a subnational certification of TB where they compare the baseline data with the 2015 data and they give monetary and non-monetary awards. So in the form of gold, silver, and bronze medals. So can we adopt the same strategy for NCD, sir? It can take us one component. For example, in TB, they take the component of incidence. So we can take the premature mortality rate in NCD and we can certify the...
First is you have to measure them at state level, no?
Yes.
If you are not measuring it, mortality is not being measured state level for two reasons. We don't, if you look at even at the SRS data, there is not enough sample size at state level monitoring. So if you want to do state level monitoring, we have to look at set in place mechanisms that we can, in TB it is much easier communicable. You just look at the program itself provides you all the necessary details for those kind of things. For NCTs, that is not going to happen.
But I think, sir, since India is committed to NTB by 2025, they are adapting these strategies. Maybe they are casual about this.
My again request is for every state program to start monitoring at state level. Then these things can be done. Without that, there is no point in theoretically saying that we should award state governments. We are not measuring at state level.
So the second point is that, sir, instead of measuring the absolute reduction in the prevalence of smoking or alcohol consumption,
it's not absolute. We are measuring relative reduction.
Okay, sir. So we can measure
decline from 2010 levels is our targets.
So we can measure age-specific reductions, sir. For example, if
that's a refinement of this. Yeah, obviously, to have a indicator is more generic. Once you do a CAT survey, you can always look at age-specific details.
Because I thought older people might quit smoking because of the complications they get.
So cessation of smoking, hardly 1 or 2%. You look at any tobacco survey in India, cessation is hardly there. It's almost non-existent. If there is 30% prevalence of smoking, 1% would have cessation or something like that. So cessation is not working. Let's be very clear at national level.
Sir, and that point is that I think we should stop justifying the moderate consumption of alcohol, because if we justify, then there might be some point where even marijuana can be a legal product as it's occurring in the West.
Yeah, so there are two issues there. I've debated this internally myself. It's also at personal use before we practice before you preach. But the general public health message is avoid alcohol. There is no question about it.
Because the matter of legal for a product lies with the government. It's not because marijuana was earlier illegal. Now it's been legal. So it's not about the product. It's about the government policies, whether the product is legal or illegal.
So generally, as I think even Dr. Ambedkar said yesterday, I'm not in favor for alcohol prohibition. But the messaging should be that alcohol has to be avoided. Right? Alcohol prohibition has its own set of problems. I think Atul talked about it briefly.
So, for example, you take the TN government, sir, Tamil Nadu government. Every time when it's Diwali or Pongal, then the news pops up. The government has hit a high time record of selling 500 crores of alcohol, 750 crores.
Tamil Nadu government sells alcohol, which is very rare thing for people. But you know, in Delhi government, they have a new alcohol policy, where now stores are giving discount on alcohol use. So we can have a lot of debate on alcohol policy. So let us not go there. So definitely government should not promote alcohol.
So we can reward behavior.
There cannot be any discussion on that.
Okay. Thank you.
Prohibition to baat ki baat hai, but definitely governments neither should sell alcohol nor should promote alcohol. That there cannot be any discussion on that.
I just wanted to ask, like, as a researcher, so how do we validate these behavioral surveillances, like use of tobacco, use of alcohol?
So these tools are already validated.
No, these validated in the sense like these are only asked as survey questions. Do you use, have you,
Yeah.
have you been smoking? So are we supposed to rely on whatever information?
Good question, especially for alcohol and this thing. There could be some bias, but these have been validated and they're reasonably good. There will always be some people who don't tell the truth, that you cannot avoid that. But largely this seems to work. For alcohol, for tobacco, there are surveys which use urinary cotinine also. There are more objective measures like that, which people have tried, but they have their own challenges. They are much more difficult. You need lab, you need to collect urine, transport them. So there is no right answer. You have to balance the difficulties and validity.
There is one room. What initiatives are in the pipeline to include the private sectors?
The private sector for health system assessment, is it? Because those are, I'm not going to ask very generic questions. Surveillance questions, yes. But involvement of private sector in NCD provision, I don't know. I'm not going to answer that question because it's not relevant to this session. But in the NNMS survey that we did, we also included private sector. So assessment part, we have included private sector in terms of availability of essential technologies and medicines. Roles of community medicine and department, talk to governments, talk to population, I think build capacity for NCD. Okay, thank you. Prashant, are you there?
Yeah, I'm there.
Sorry to have kept you waiting.
No, I'll stand between lunch and talk.
No, there is one more speaker.
Yeah, I know that. Mohan is there.
Okay, so maybe Dr. Prashant Mathur is the director of National Center for Disease Informatics and Research in ICMR institution in Bengaluru, and he heads all cancer registries, and also they're doing stroke registries and many other disease registries. And he was the chief coordinator for the National NCD Monitoring Survey that I talked about. So over to you, Prashant.
Thank you. Thank you very much to you and Dr. Thakur and your entire organizing team for this wonderful course that you run annually. And I do understand that the richness of your participants has been increasing. So thank you all for being there, and greetings to all the participants. I'll just share my presentation. Is it visible?
Yes, sir, it is visible.
Okay, so Dr. Anand has laid down the foundation of what I'm going to speak now. And so what I'm going to speak is assessment of health systems preparedness for NCD control, and how disease registries and other tools help us. And this is going to be more of a showcasing what has been done primarily by us, but not withholding. There are many other people also who are doing these activities and systems. So, but as a snapshot to give you that flavor that yes, things are being done, and it's not that we are totally in a vacuum of not being able to do many of these things. So we know that public health approaches for NCD prevention and control need to address the entire population, because we need to address issues of inequalities. We need to address multi-sectorality, because NCDs is a problem which is actually not a health department's problem. Health department is a victim of the ills which are done by other departments and ministries and other sectors of the society. We only get to bear the brunt of those ills which have been done. And so, but being the health department and health people need to be the advocates for calling on for multi-sectoral action, and to have a long view of influencing people's health and the population. And so surveillance is a key tool by which one not only collects data, but also informs policy actions, and also to see whether we are on the right track, how fast are we going, how slow are we going, and many things as was discussed through the indicators which were shown. Now, I've just tried to list some components when we say health systems preparedness. Now, health systems preparedness is the primary thing is that we must have information on the epidemiology, burden, and trends of non-communicable diseases and their determinants. Because unless we do not have this information, there is no point a health system preparedness could even start. So you need to know what is the problem, what is the size of the problem, and what is the determinants of the problem. And this aspect, all public health practitioners, all clinicians, anybody who's involved in giving healthcare, whether doctors, whether paramedical staff, nurses, everybody must be aware of these components, because then that becomes a total health systems preparedness. The major component which we normally understand is, provisions of healthcare service delivery. And this includes infrastructure. So opening new hospitals or revamping systems and facilities, providing the equipments over there, and arranging adequate financing, supplies, and most important is not only human resources in terms of numbers, but also in terms of skill sets. The health systems also needs, as part of their delivery services, need to engage with the community which they serve. So they need to understand the demand, the satisfaction level, as well as obtain regular feedbacks from the community that they serve. The third component of health systems preparedness is monitoring, evaluation, and surveillance. And all three are different concepts, but they work complementary to each other. And we heard just now about some process and outcome indicators. All national programs, everything has built-in process indicators. We need to do regular audits and provide feedbacks. Most importantly, there has to be a sense of proactiveness to be able to anticipate a problem, to be able to anticipate trouble. And this can be done through very small local facility or system-based assessments also. But for that, you need tools. And these tools need to be simple so that everybody can understand. They need to be flexible so that they can be contextualized to the local needs, reliable, consistent, validated. And once you achieve some of these qualities of the tool, the user becomes happy and these tools are used more frequently. And many of us would have had first-hand experience when tools are too large, they are unreliable, they are vague. And most important component of health systems research from ICMR's point of view is research. We need that kind of research to inform on health systems preparedness so that we know whether we are on the right track, what else can we do, what are the gaps in the current system, and are there any new developments in science, in clinical sciences, in public health, which can be brought in to improve the health system's preparedness. So from NCDIR, we run the National Cancer Registry Program, and we have been running it for 40 years. So we are into the 40th year of running the National Cancer Registry Program. So generally, we now say that registries are the eyes and ears of health system. They help us in monitoring the trends of health and disease, allocating resources, priority setting, healthcare planning, improving the quality of care given, monitoring impacts and of the interventions, ensuring better global data on disease surveillance, because ultimately we need some global comparisons to know, and if we have to achieve the SDG targets, some kind of a global comparability should be there. And obviously the registries only give you an information, so they are more of hypothesis generating. They will tell you a situation for which you will ask questions, and some research should be undertaken to answer those questions. When you answer those questions, there will be a new set of questions, and this is the continuum of research. So as I said, we are running the National Cancer Registry Program. On the left side, what you see is the map showing our population-based cancer registries. We have 38 population-based cancer registries. Mind you, cancer is not yet a notifiable disease in India. However, through the consistent efforts of the National Cancer Registry Program, there are 14 states which have notified cancer as a notifiable disease through either an administrative or a gazetted order. And that helps a lot in cancer registration. We run an active cancer registration process, which is quite troublesome, which is quite cumbersome, which is quite painful. And so it impacts a lot of performance of cancer registries. And many of us get impressed when we look at registries from many developed countries and assume that why can't we do it? We need those provisions to make cancer a notifiable disease, just like you have TB and many other diseases. Population-based cancer registries are located at the locations which are indicated by the name. It has a defined geographic area which it covers. It could be an urban setting, it could be a rural setting. And people living in that area of all ages and all genders who have been residing there for at least 1 year before the diagnosis of cancer was made are eligible for being included in the population-based cancer registry database. It collects data on all cancers, all ages, and in a 365 days year, it collects mainly through health facility systems, both in public and in private sector. On the right-hand side, you see the hospital-based cancer registry map, and we have now around 180 hospital-based cancer registries. Numbers keep fluctuating up and down. Many hospitals register, but they stop transmitting data after some time, So, but they are spread out in all across the country, and they collect data on the cancer cases which attend that particular hospital. They can be attending from any part of the city or the country. And it helps in actually collecting very high quality data on the clinical aspects, the management aspects, and outcome of cancer patients. Both type of registries complement each other and help a lot in giving information on incidence, trends, burden, mortality, outcome, and survival of cancer. There is a third mode, which is a cancer atlas mode, and we have finished 3 cancer atlases. We started with one which was an all India cancer atlas in 2001 and 2, which for the first time in the country provided district by district data on cancer. And that was an eye opener even to the government that this is the kind of burden of cancer that we are sitting on. After that, we ran the Punjab Cancer Atlas, we ran the Haryana Cancer Atlas, and we have very recently concluded the Karnataka Cancer Atlas project with the state governments. We are initiating one in Rajasthan, and there are dialogues works with some few more states who want to do a state-wise, district-wise cancer atlas mode. We published the latest report on population-based cancer registry statistics from 28 population-based cancer registries, and these are available on our website. And this is a snapshot of the kind of data you get. So on the left, on the y-axis, you see the registries being listed for males and females. This is for incidence for all sites of cancer for the year 2012 to 16. And the color coding shows the region. So we see that in males, the highest incidence is from Aizawl district in Northeast with 269 per 100,000 population. And then you can see more registries from the Northeast. And then, you know, the least cancer incidence that we recorded was from the Osmanabad and Bid in Maharashtra of around 39 per 100,000. And a similar story you see in females. So India is not one country, it's a mix of countries. And so the question we need to ask is that, does one intervention serve all India, or we need some regional, some state level, or some disaggregated intervention, somewhere very aggressive, somewhere we can go at a slower pace also. Based on these 28 registries, this is a heat map showing the top 3 causes of cancer, both in males and in females. So what we see is cancer, lung, mouth, and stomach, esophagus, were the most common cancers among males, whereas in females, it was cancer of the breast and cervix uretry. So both breast and cervix, they compete with each other. Somewhere it is breast is number 1, somewhere cervix is number 1. But largely in India, breast has overtaken cervix a long way back. And so the 5 common cancers are breast, lung, mouth, cervix, tongue. And this is the kind of information which is provided to the Ministry of Health and which they use for various cancer policy making, prevention and control program. And this has been going on for last 40 years. This is another kind of a heat map which shows the age specific incidence rates for cervical cancer. And it does show that where the incidence rates, at which age group is it rising, and what is the kind of age when we need to. So though there is a screening program for oral breast and cervical cancer, the registry data will give us an insight to let us know whether we need to tweak anything in the screening program. Maybe the age group needs to be tweaked. Maybe even the regions may not be that all regions of the country need to be screened as aggressively. So the global elimination target for cervical cancer says that we need to bring down the incidence rates to 4 per 100,000. And some of our registries, Dibrugarh registry in Assam is almost there at 4.5 per 100,000. And there are many more around between 4 and 8. So it doesn't mean that we have reached the target. We are moving towards it, but we do not need to slacken the speed. So age incidence curves are also available. Then we did a last 20 years annual percentage change of cancer. So what you see, the red lines are the cancers and the registries where it is increasing, and the green lines bars are those where it is decreasing. So the good news is that cervical cancer is reducing at quite a satisfactory pace, although we still do not have HPV vaccination. And even screening programs are still in their infancy. But something else is happening, whether it is in terms of parity, whether it is age of marriage, literacy, overall hygiene, everything together is making an impact. But worrisome, as I said, breast cancer in females is showing an increasing trend. So these are population level figures. These are population dynamics of cancer, which is going down, which are being shown here. So you can see even stomach cancer is reducing. To supplement our population-based cancer registries, because cancer registries were typically collecting data on the cancer incidence, but we did not know that what was driving those incidences. So we just completed a risk factor survey for cancers in the defined population-based cancer registry area in all 8 states of the Northeast. And this report is released and it's available on our website. You are welcome to go through this report. It gives a very good exposure factor information. It gives information on some social determinants. And also it also gives an information on the health system's preparedness for prevention and treatment diagnosis of cancer. And if we continue to repeat these, so these population-based cancer registry areas have now become very ideal cancer surveillance sites. So we have risk factor determinant data, we have morbidity data, we have mortality data, and we have health systems data. And we were pretty, surprised, shocked, not pleased to know that what is going on. We have a very high exposure levels which are going on. So even if we keep opening hospitals, even if we keep more radiotherapy machines, the supply of cancer is not going to stop unless these risk factors are not controlled well, whether it is in the area of solid fuel use, tobacco use, alcohol use, intake of fruits and vegetable, and also in some parts of Northeast, consumption of very high salt curated, preserved and fermented food products is there, which drives a lot of esophageal and stomach cancers in the area. Now, this is the kind of information which we have shared with the various state governments, health departments, to let them know where to intervene. Because when we go with our cancer registry and incidence reports, they're helpless. They don't know what to do. They say what, so the automatic reaction is to open more hospitals, to treat people. But the question is not about treating people. It is also the question about reducing where the number of incident cancers. And that is also addressing the global NCD target, where we need to reduce these cancers and then mortality. When we looked at the health systems, we saw that only 7% of the current tobacco users received advice to quit tobacco, and 3% were receiving advice to avoid alcohol. Now we know in the Northeast, the very high rates of tobacco use, very high rates of alcohol use. 8% received advice to maintain a healthy body weight. And in 27%, their blood pressure had never been measured. And in 60%, their blood glucose was never measured. Now, these are little, shocking results when we look at cancer prevention and control in totality. And this also is an assessment of how well our health systems in primary care functioning. And this is again continuing that less than 2% had received advice to undergo screening for every of the 3 common cancers. And 1% of female respondents had undergone cervical cancer screening. And similarly, very low figures for breast cancer and hardly much there for oral cancer. And Northeast is a very high smokeless tobacco consuming zone. 30% households reported that a cancer death had happened within 6 months before death. Now, from the registry data, we know that in India, we see late stage cancer. Almost more than 2/3 of our cancers, any site, are stage 3 and stage 4 cancers. And so mortality is very high. Treatments are expensive. Complication rates, adverse events are highest, and survival is poorest. And this corroborates that 30% said that the diagnosed cancer patient in the family died within 6 months of diagnosis. And 30% were seeking care outside the state. And this is something which drains out cancer, and we hear a lot about out-of-pocket expenditure, cancer, financial toxicity. And these are the kind of data sets which corroborate this and also call for action. And only 6% were covered by a health insurance. To continue this story, because when we talk cancer, we are too much fascinated by adult cancer. So childhood cancer is something which is totally neglected in our country, although childhood cancers in totality account for 4% of all the cancers which are seen. And so we have just completed a situational analysis of childhood cancer care services in India. And this includes public as well as private hospitals in 27 states of the country. And we have spoken to the state NCD nodal officers. There is a dearth of shortage of trained people to tackle childhood cancers. There's a shortage of nursing staff. There is laboratory diagnosis is a bigger challenge. Treatment abandonment, where treatment either is not started, or even if it is started, it is not completed and cured. And so these are the kind of this is the kind of analysis which opens our eyes to see how well are we prepared to tackle childhood cancers. Now, moving the story from cancers to stroke, we are running the National Stroke Registry program also. So like cancer, we have 5 population-based stroke registries, which you see in the blue color. And we have a number of hospital-based stroke registries. Again, same format, collect stroke data on defined populations in population-based stroke registry, collect data on clinical aspects of stroke from the hospital-based stroke registry. It helps us to map the pattern of patient care, assess the quality of stroke services which are being given. And on the last World Stroke Day, we released our National Stroke Registry report, first time in the country, looking at 5 regions across the country from Cuttack, Tirunelveli, Kota, Varanasi, and Kachar in Assam. You look at the crude rate and the age standardized incidence rates per 100,000 population for first ever stroke. And the highest crude incidence rate was reported in Cuttack of 187, and the lowest was 96 in Kachar. Similarly, we looked at the crude case fatality rate and the age standardized fatality rate through the population-based stroke registries, looking at both the genders, which was highest in Varanasi, followed by Kachar, Cuttack, Tirunelveli, and Kota. We are also completing the analysis of the report of setting up heart failure registries in select parts of the country, which will give us information on the etiology, diagnosis, management, comorbidities, outcome, and survival of. How come this is moving on its own? What happened? Okay, so this was the heart failure registry. So there are a lot of questions one can ask through the registry data, whether it is assessing natural history and clinical patterns, patterns of care and survival studies, which we are very effectively running for both cancer and stroke, determining the clinical effectiveness and other studies, cost effectiveness studies, monitoring adverse events, and improving the quality of care. The other dimension, now coming back from morbidity to risk factor, and this was the survey which Dr. Anand was referring to, the National NCD Monitoring Survey, which we did in 2017 and 18, responding to the country's National NCD Monitoring Framework and Action Plan, 10 targets,
Excuse me, sir.
Yes.
Sir, we are running a bit behind the schedule, so if you
Okay.
can finish in 5 minutes.
Okay. And all of them have got tracer indicators. And we collected data on adults from 18 to 69 and adolescents from 15 to 17 years of age group. This report is voluminous. You can go through our website, NCDR website, download the report. Anybody interested in getting hard copies is most welcome to write to us and we will provide it to you. Now, this was an amalgamation of several global standardized tools, WHO STEPS, GHSS, GATS, SARA, and the IDSP NCD risk factor survey we did. For the first time, we have done urinary sodium estimations for salt consumption and health facility at both the public primary, public private, as well as for the secondary level of health facilities. We also collected some generic information at household level, at population level. And this is the risk factor profile we get. As I said, salt we did for the first time, and average consumption of salt is 8 grams per day. Insufficient physical activity is 41%, and so on. And there is a lot of clustering of more than 3 risk factors. Similarly, we have done these assessments for adolescents, which we took from 15 to 17 years of age group, because the indicator said for adolescent, we have taken from 15 to 17. And around 30% of them received counseling to prevent heart attacks and stroke. This is another eye-opener from health systems point of view, the hypertension and diabetes control cascade. Overall prevalence of hypertension was 28%, but only 30% were aware of their hypertension, 14% were on treatment, and 12% under control. Similarly, for diabetes, out of the overall prevalence of 9.3, 45% were aware, 36 were on treatment, and 15.7. So we know the gap in the control of hypertension and diabetes. I will not go through all these details. These are available in the reports. One can look at the services in terms of being provided in the public primary, public secondary, whether CHCs or district hospitals, in terms of human resources and the skills available, how many are available, how many were trained, and also looking at availability of essential medicines, technologies in both the public as well as the primary as well as the secondary care hospitals. After this, we have very recently done a 10 district study on continuum of care for diabetes and hypertension in 5 states of the country, both public and private, from primary, secondary, and tertiary levels. And very fascinating preliminary results showing on the availability of the services and the limitations. So there are patient exit interviews which were taken to assess satisfaction levels, to obtain feedbacks of the services. And this report is still under finalization, which we hope that we will be able to very well share it with the state program managers to look into this. So as I said, it was giving patient perspective also. So to conclude, what we have understood through our work is that if you need to assess health systems preparedness, we need multiple methods of information and multiple sources of information are needed. And we do a lot of research, but many of our research doesn't reach a logical policy level. And we must find ways of making the research recommendations way into policy and program. Working very closely with health systems, working very closely with the governments, with the primary care providers is absolutely essential if one has to ramp up the health systems preparedness. And as I said in my opening slide, that research will be a critical component in fine-tuning and sharpening our health systems preparedness for NCD prevention and control. Thank you all very much. You are most welcome to visit our website and look at our Facebook, Twitter handle, and on LinkedIn also. Thank you very much.
afternoon, sir. Can I ask a question?
Yes, please.
So thank you for enlightening presentation. Sir, if we want to establish a population-based cancer registry, is there any financial support or technical support available from the ICMR, especially in context of the medical colleges?
Yes, yes, we do. But setting up of a population registry, based cancer registry, requires much more than finances. It requires a very well assessment of the area, the purpose, and how the government, because a population-based cancer registry results become meaningful minimum after 3 to 5 years of its establishment. So it's not like a cross-sectional survey that immediately you get results. But certainly those interested at medical college level, we can get in touch with us and we can work around it.
Okay, sir. Thank you so much.
Am I audible, sir?
Yes.
There was some network issue, sir, from here.
Okay. Yeah, I can hear and see you all. I cannot hear anything if in case something is being said.
We can just
The voice is breaking. I cannot hear. Maybe if you can type the question or comment in the chat box, I can respond to it.
There is one online question, sir, I think, in the chat box.
That online one is about the PBCR finances, isn't it?
Hello, sir.
Yes.
Sir, I have a doubt, sir. You have mentioned about the multicentric cancer registry and the stroke registry, which is good. But you also said that the mean survival after the stroke in various cities were, I mean, up to 28 days were around close to 30 to 40%. So what is the purpose of, I don't see a purpose other than the palliative care for stroke and cancer registry. Rather, I was interested in the diseases like diabetes and hypertension. So yesterday, our respected Dr. Anand sir said about the young diabetes registries for newly diagnosed people less than 25 years. But I feel the death due to IHT is the largest and resultant of which is as a result of hypertension. So is there a regional or national attempt to develop a register for hypertension so that we can identify the target groups? Because in cancer and stroke registries, already the event has occurred. So at the most, we can give them a palliative care. But if we identify the priority group in, I mean, pre-hypertensive patients through the program of national registry, that will serve the long-term purpose. So can you please locate me any program running in national or regional level, sir?
So the registry or survival or outcome in cancer and stroke is not just palliative care. We would be very much interested in knowing 5-year survival rates for, let's say, breast cancer, stage 2, stage 3. And this is very much important for any clinician, or even the patient would like to know, once diagnosed with cancer, what is the duration of likely survival. So survival is a very important component of both of any chronic disease. Okay. The other question about hypertension registry, I'm not aware of any hypertension registry, but it forms part of many registries. Like for example, the heart failure registry that we run also captures information on hypertension. There is the ICMR Ministry of Health and WHO led study on India hypertension control. Then there is an ICMR run MACE registry, management of acute coronary events. These registries in totality give you an information on the hypertension which is happening. Diabetes registry, yes, ICMR never thought of setting up a routine type 2 diabetes mellitus registry because it's a very vague disease to be captured in a registry form. So the focus was young diabetes. We now have type 1 diabetes, we have neonatal diabetes. These are registries. Otherwise, the most efficient way of diabetes recording is through cross-sectional surveys. So what we showed, one was the NNMS, the second, which is the ICMR-led INDIAB study, which is given statewide prevalence of diabetes, risk factors, determinants, and there is complication rates also. So we may not, it's not a very efficient way of having registries for risk factors and diseases, diabetes and all, which are so diffuse that it's very difficult to follow up patients with diabetes and hypertension.
Sir, but detection of hypertension is far easier than detection of cancer because ASHAs are able to screen for cancer. Hypertension. Rather, the CBAC forms are not filled for the cancer column. So I feel the register for hypertension is more easier to. I mean, I may be wrong.
There is the whole entire hypertension screening program is a registry in itself. So the data is being collected. It is being supposed to be stored at various levels within the health system profile. There is an entire NCD app. So it almost functions like a registry.
Thank you, sir.
Sir, there is an online query from the online participant. The query is there any financial assistance to establish?
Yeah, that I have answered already. That I have answered. I think you got the answer, Ankita.
So we were not able to hear as the network, we had a network issue.
So my answer was yes, we do take up proposals on setting up population-based cancer registry. But as I said, finances is not the only criteria. It requires a very extensive level of planning and looking at the governance structures, etc. Who will run it? Okay. Because the fruits of a population-based cancer registries come minimum after 3 to 5 years of their setup. So it's not like a cross-sectional survey, and one must have a very long vision of setting up. So yes, good proposals are funded.
Thank you, sir. So there is one more question in the chat box.
About nurses.
Yes.
Now, this is something which, the local state managers only can answer about shortages. So I don't know. So it's a problem, but the solution lies in filling up the vacancies and putting up more sanctioned posts as and where it is needed. The question I see is, how is ABDM going to impact cancer registry? It is going to help us in a big, big way. And as I said, cancer is not yet a notifiable disease. This ABDM will help us, because today what happens is one cancer patient moves across the entire country for diagnosis and treatment. How do you capture this? At every time, a new name, incomplete name, different age, different mobile number, etc. is given. So we don't know that the same Ramlal, it is the same Ramlal which is moving in 5 different hospitals. But we still are able to capture it by using our software technology. But Aadhaar didn't help us a lot. But yes, we are very hopeful of ABDM to be helping us. It will be taking us towards the purpose of notifiability also.
Thank you, sir, for your presentation. Sir, there are no more questions now. So we can move to the, sir, actually, we have lunch break. So we will be going through lunch break, then we will join for the next session.
Okay. Thank you all. Thank you very much for being there. And any future correspondence, you have to take your mails for that. Thank you.
Thank you, sir.
Online participants can join us at 1:45.
We will be joining back at 1:45. So have the lunch